are nulliparity, family history, and hereditary factors. Generally, ovarian tumors occur in perimenopausal and postmenopausal women and are infrequent in children. Women between 40 to 59 years of age who have taken oral contraceptives for long duration or undergone tubal ligation have reduced risk of developing ovarian cancer comparatively. Early diagnosis of ovarian cancer is important to decrease morbidity and mortality associated with it. The WHO classification of ovarian tumor is based on the tissue of origin, and this reflects the embryogenesis of this complex organ. The complex nature, the unpredictable behavior, and prognosis make ovarian tumor a difficult problem for the gynecologist. The ovarian malignancy has poor survival as they clinically don't manifest in early stages, and approximately 60 to 70% present as either stage 3 or stage 4. Benign ovarian tumors are the commonest lesions and comprise about 80% of ovarian tumors and occur in young women between the ages of 20 to 40 years. The borderline tumors, they occur at a slightly older age, whereas the malignant tumors are common in older women between the ages of 40 to 65 years. The most important clinical feature is the age of the patient. Laterality of the tumor also provides an indirect clue to the nature. The gross features may also help in differential diagnosis and represent the integral behavior of tumor. Like most benign tumors of epithelial category are cystic. And on the other hand, the finding of solid elements and papillary projections make malignancy more likely. The histogenesis of many tumors is interrelated, and accurate histopathological diagnosis is needed for effective treatment. Now, a brief overview of the ovarian tumors before I go on to my study. Most tumors of the ovary can be placed into one or the three major categories. First one, surface epithelial stromal tumors. Second, sex cord stromal tumors. And third, germ cell tumors. And this is according to the anatomic structures from which they presumably originate. So this is the diagrammatic representation of the ovary. The surface epithelial stromal tumors, they arise from the germinal coelomic or the surface epithelium of the ovary, and these give rise to the serous, mucinous, endometrioid, clear cell, and transitional cell tumors. Second, the sex cord stroma of the ovary. This gives rise to the granulosa cell tumors, thecoma, fibroma, Sertoli cell, Sertoli Leydig cell tumors, and steroid tumors. And thirdly, the germ cells present in the follicles, these gives rise to dysgerminoma, yolk sac, embryonal carcinoma, choriocarcinoma, and teratoma. The 2014 WHO classification of ovarian tumors is as follows. It is divided into epithelial tumors, mesenchymal tumors, mixed epithelial and mesenchymal tumors, sex cord stromal tumors, germ cell tumors, monodermal teratoma, and somatic type tumors arising in dermoid cyst, germ cell sex cord tumor, stromal tumors, miscellaneous tumors, mesothelial tumors, soft tissue tumors, tumor-like lesions, lymphoid oblique myeloid tumors, and secondary tumors. The surface epithelial tumors. Surface epithelial stromal tumors are classified as benign if they lack exuberant cellular proliferation and invasive behavior, as borderline, also known as atypically proliferating or of low malignant potential, if there is exuberant cellular proliferation but no invasive behavior, and as malignant if there is invasive behavior. Surface epithelial stromal tumors account for approximately 60% of all ovarian tumors and approximately 90% of malignant ovarian tumors. 5 major subtypes are included within the surface epithelial stromal group. They are designated as follows: serous, mucinous, endometrioid, clear cell, and transitional cell or Brenner type. Highly malignant epithelial stromal tumors lacking any specific differentiation are classified as undifferentiated. Epithelial stromal tumors that are not designated as having a specific subtype commonly are recorded as adenocarcinomas, not otherwise specified. Now, serous tumors are epithelial stromal tumors formed by cells that resemble those of the internal lining of the fallopian tube. Benign serous tumors are thin-walled cysts formed by a single chamber filled with a watery, straw-colored fluid. The internal lining of the cyst is usually flat, but may display a few coarse papillary projections. Compared with benign tumors, borderline serous tumors have a more exuberant and finer papillary projections within the cyst cavity. Similar projections also may occur on the external surface of the tumor. Most malignant serous tumors are at least partially cystic. They may contain multiple cyst chambers or loculations and also solid areas. Most display an abundance of delicate papillae that project into the cyst cavities and in some cases outward from the external surface of the tumor. So this is the gross picture of a benign serous cyst adenoma showing a uniloculated cyst having a flat surface. And this is the photomicrograph showing the cyst lining lined by cuboidal, flattened to cuboidal cells. So now this is the gross picture of a papillary serous cyst adenocarcinoma where we can see a cyst and which numerous papillary projections can be appreciated along with areas of hemorrhage. And on the microscopy, we can see the papillary configuration, and these papillae are lined by atypical malignant cells. Now, mucinous tumors, they are epithelial ovarian tumors formed by cells that resemble either those of the endocervical epithelium, known as the endocervical or Mullerian type, or more frequently, those of the intestinal epithelium, known as the intestinal type. Benign mucinous tumors are multiloculated cysts that are filled with opaque, thick mucoid material. Malignant mucinous tumors may contain more papillary projections within the cyst cavities, larger solid areas, and larger areas of necrosis and hemorrhage. Endometrioid tumors. Endometrioid tumors are epithelial ovarian tumors formed by cells that resemble those of the internal lining of the uterus, the endometrium. Carcinomas are considered to have a better prognosis. Endometrioid carcinomas are considered to have a better prognosis than either serous or mucinous carcinomas. This is the photomicrograph of an endometrioid carcinoma. Clear cell tumors. Clear cell tumors are epithelial ovarian tumors that are formed by clear, peg-like or hobnail-like cells. Most clear cell ovarian tumors are malignant. They can be predominantly solid or cystic with one or more polypoid masses protruding into the lumen. This is a clear cell carcinoma of the ovary where we can see some hobnailing and clear cytoplasm of the cells. Transitional cell Brenner's tumor. Transitional cell tumors are epithelial ovarian tumors that are formed by cells that resemble those of the internal lining of the urinary bladder, that is the transitional epithelium or the urothelium. These tumors presumably are derived from ovarian surface epithelium that undergoes urothelium-like transformation, that is urothelial metaplasia. However, sometimes it is said to originate from the Walthod cell nest also. Most benign transitional cell ovarian tumors are very small, asymptomatic, incidentally discovered, and clinically irrelevant. They are solid and nodular, and most are unilateral. So this is a photomicrograph of a benign Brenner's tumor. Malignant transitional cell tumors also contain solid areas and cystic areas with internal papillary or polypoid projections. They are referred to as transitional cell carcinomas when they lack benign transitional cells, and as malignant Brenner's tumors when benign transitional areas are identified. The sex cord stromal tumors, they are ovarian tumors that are believed to originate in theca cells, other stromal cells, granulosa cells, and their testicular sex cord counterparts, that is the Sertoli and the Leydig cells. These tumors often are associated with endocrine manifestations. So granulosa cell tumors, two major forms of granulosa cell tumors are recognized. The adult form, which primarily occurs in middle-aged and older women, and the juvenile form, which typically occurs in children and younger women. Most adult granulosa cell tumors are partially cystic, with multiple fluid-filled or blood-filled loci and solid areas. They are considered to be tumors of low-grade or low malignant potential. They are the ovarian tumor type most commonly associated with manifestations that are caused by overproduction of female sex hormones, that is estrogenic manifestations, and also including the endometrial hyperplasia and endometrial cancer. Fibromas. Fibromas are rare solid ovarian tumors arising from the spindle stromal cells that form collagen. Fibromas are the most common during middle age and are rare before 30 years. In almost all cases, they are benign and curable by surgical excision. Fibromas with increased cellularity and cell proliferation are rare and follow a malignant course. Sertoli cell tumors, they are rare sex cord stromal ovarian tumors formed by cell proliferations that resemble the rete ovary and rete testis, which characteristically are arranged in hollow or solid tubules. The mean age at diagnosis is 30 years. Most of these tumors are unilateral and stage 1. They form solid, yellow, or brown lobulated masses, and they rarely metastasize. Now, 5 subtypes of Sertoli cell tumors have been identified, that is, well differentiated, of intermediate differentiation, poorly differentiated, retiform, and mixed. After this, the germ cell tumors. Germ cell tumors are ovarian tumors formed by cells that are believed to be derived from primordial germ cells. More than half of the ovarian neoplasms that develop in children and adolescents are of germ cell origin, with 1/3 of these being malignant. Conversely, in adults, germ cell tumors are relatively infrequent, and the great majority of them are benign, with the most being mature cystic teratomas. The prototypical germ cell tumors are the dysgerminomas. Embryonal carcinoma are germ cell tumors composed of poorly differentiated multipotential germ cells. Germ cell tumors with differentiation in an embryonal or somatic direction result in teratomas. Those that differentiate in an extra embryonic, that is placental or trophoblastic direction, result in yolk sac or choriocarcinomas. Mixed subtypes of germ cell tumors also occur frequently. So dysgerminoma, it is tumor composed of cells that are similar to the primordial germ cells. They display a striking similarity to their testicular counterpart, the seminoma. It has solid white or grayish white appearance on gross morphology. It is the most common malignant neoplasm during adolescence and early adulthood. So these are the nest of uh, the cells surrounded by fibrous septae which contain lymphocytes. Yolk sac tumors, also known as the endodermal sinus tumors, are germ cell tumors displaying cellular structures that resemble those of the primitive yolk sac, the vitelline elements. These tumors are mainly solid but frequently have cystic spaces. They are highly malignant, frequently invading the surrounding structures and exhibiting extensive spread within the abdominal cavity. Yolk sac tumors produce alpha fetoprotein. Embryonal carcinomas, they are germ cell tumors formed by primitive cells that resemble those of very early embryonic development. They are large, predominantly solid tumors with a variegated appearance, and most are unilateral. Choriocarcinomas, they are germ cell tumors formed by placental, namely trophoblastic cellular elements. They typically are solid and have a hemorrhagic appearance. Serum levels of HCG hormone may be used as a tumor marker. Teratomas are germ cell tumors that are formed by cells derived from more than one of the three primitive embryonic layers, that is ectoderm, mesoderm, and endoderm. Teratomas can be mature or immature. Teratomas formed predominantly by endodermal or ectodermal elements are referred to as monodermal or specialized. Mature teratomas can be solid or cystic. Mature cystic teratomas are the most common kind of ovarian germ cell tumor. In most mature cystic teratomas, the ectodermal elements predominate. When this is the case, these teratomas are designated as dermoid cysts. Mature cystic teratomas commonly have a single cyst cavity filled with sebaceous material, and they often have focal internal protuberance that may contain hair, teeth, bone, and or cartilage. And immature teratomas, they contain primitive, immature, or embryonal structures, in addition to well-developed or mature tissues. These tumors usually are unilateral, large, and predominantly solid. They are rare and most frequently occur in the first 2 decades of life. Now, with this overview, I'll start with my study. The title of my study is The Histomorphological Spectrum of Ovarian Tumors in a Tertiary Care Center in North India. The aims of our study was to analyze the frequency and diverse histomorphological spectrum of ovarian tumors. The material and methods. It was a retrospective study conducted for a period of 3 years in histopathology section of the postgraduate department of pathology. All histologically proved cases of ovarian cancer tumors were included, and exclusion criteria were normal ovaries and ovaries with non-specific findings like follicular cysts, cystic follicles, endometriosis, tumor-like lesions such as stromal hyperthecosis, stromal hyperplasia, fibromatosis, and massive edema of the ovary. Clinical data pertaining to patients' age, sex, and site were recorded from the requisition forms and data registers. Specimens sent in 10% formalin were routinely processed with paraffin embedding and after adequate fixation. Paraffin sections and slides from the blocks were stained with H&E. Special stains like PAS and reticulin were done whenever required. The slides were then reviewed microscopically in detail. The tumors were classified according to the WHO classification of ovarian tumors into surface epithelial tumors, benign, borderline, and malignant, germ cell tumors, sex cord stromal tumors, and metastatic tumors. Immunohistochemistry was advised in poorly defined malignant neoplasms or when difficulty was experienced in typing the malignant tumors correctly. The observations were 194 patients formed the material of the study. Majority of the patients were seen in the 5th decade of life with age range of 21 to 76 years. On histopathology, out of 194 cases, 86.6% were benign, 3.6% borderline, and 9.8% malignant. Surface epithelial tumors were the commonest tumor, 69.6%, followed by germ cell tumors and sex cord stromal tumors. Among the surface epithelial tumors, serous tumors, 82.2%, they were the commonest, followed by mucinous tumors. Serous cystadenoma was the commonest epithelial tumor, followed by mucinous cystadenoma, serous cystadenocarcinoma, and serous cystadenofibroma. Among Germ cell tumors, mature cystic teratoma was the commonest tumor. Single case each of immature teratoma, dysgerminoma, and yolk sac tumor was also seen. 8 cases of sex cord stromal tumors were seen, including 4 cases of granulosa cell tumor and 2 cases each of fibroma and fibrothecoma. All the sex cord tumors were benign. Now, this is the table depicting the histopathological spectrum of ovarian tumors in our study. There were a total of 194 cases, and surface epithelium tumors comprised the largest majority, 135 cases. Benign serous cystadenoma, 82 cases, serous cystadenofibroma, 12 cases, mucinous cystadenoma, 15, Brenner's, 3 cases, borderline serous cystadenoma, 5 cases, borderline mucinous cystadenoma, 1 case, Brenner, 1 case. In malignant cyst adenocarcinoma, 12 cases, mucinous cyst adenocarcinoma, 3 cases, and malignant Brenner, 1 case. In germ cell tumor category, mature cystic teratoma was seen in 47 cases, immature teratoma, yolk sac tumor, and dysgerminoma, 1 case each. Sex cord stromal tumors, they included the fibroma, 2 cases, fibrothecoma, 2 cases, 4 cases of granulosa cell tumor. Coming to the discussion, ovarian tumors may remain undiagnosed for a long period because of their anatomic location. Ovarian tumors cause abdominal pain and abdominal distension in majority of the cases. They are considered to be one of the most complex tumors in women in terms of histogenesis, clinical behavior, and malignant potential. Repeated ovulatory rupture and repair theoretically creates opportunities for malignant gene mutations and might explain the apparent protective effect of oral contraceptives, late menarche, early menopause, multiparity, and breastfeeding. Though no age group is free from the tumors, different tumors tend to involve different age groups preferentially. The complex ovarian anatomy and its peculiar physiology with the constant cyclical changes from puberty to menopause gives rise to a number of cell types which is capable of giving rise to tumors. Cellular and molecular biology have extensively studied the role of oncogenes and tumor suppressor genes in ovarian carcinoma. BRCA1, BRCA2, and P53 mutations are associated with increased risk. BRCA1 and 2 together have been found in 90% of the ovarian breast malignancy. National Institute of Health has advocated the use of TVS for the diagnosis of ovarian tumors. The microscopic appearance of the tumor is the most essential part in evaluation of ovarian neoplasms to find the histopathological pattern and to guide the clinician regarding appropriate management. 194 cases of ovarian tumors were included in our study. Majority of cases were seen in the 5th decade of life with an age range of 21 to 76 years. The results were comparable to previously published studies. Majority of tumors in our study were benign tumors, 86.6%, followed by malignant tumors. Borderline tumors were seen in 3.6% cases. The results were similar to previously published studies. Most of the primary ovarian tumors belong to the epithelial tumors category, which was comparable to previous studies. The germ cell tumors and sex cord stromal tumors accounted for 25.8% and 4.1% cases, respectively, in our study. Among the epithelial tumors, majority of the lesions were benign, followed by malignant tumors, and the rest were borderline. The findings were comparable to the studies conducted by Kula Deepa AVK et al. And Sharma I et al. Among the epithelial tumors, serous tumors were the most common, followed by mucinous tumors. Serous cystadenoma was the commonest epithelial tumor, followed by mucinous cystadenoma and serous cystadenocarcinoma and serous cystadenofibroma. Majority of the germ cell tumors were benign and included mature cystic teratoma, similar to previous studies. Single case each of immature teratoma, dysgerminoma, and yolk sac tumor were also seen. Granulosa cell tumor was the commonest sex cord stromal tumor seen in our study, followed by fibroma and fibrothecoma. All sex cord tumors observed were benign in nature. Sex cord stromal tumors have diverse histomorphology and may mimic epithelial or mesenchymal tumors. A panel of histochemical markers is required to confirm the diagnosis. The role of histopathology is critical in recognizing the distinct patterns of ovarian tumors as they have different epidemiological and genetic risk factors, precursor lesions, pattern of spread, response to chemotherapy, and prognosis. Now, some of the micro photographs from my study. First one, papillary serous cystadenocarcinoma. So this is the this is showing the papillary configuration in the case of papillary serous cystadenocarcinoma. And in this focus, we can see stromal invasion. Here we can see the stromal invasion on the high part. Mucinous cystadenoma. This was a case lined by mucinous epithelium of the endocervical type and was reported as benign mucinous cystadenoma. A borderline mucinous tumor. In this case, we can see the complex arrangement of the papillae, and these are lined by the mucinous epithelium, which was showing only a mild nuclear atypia. No evidence of stromal invasion was seen, and hence it was reported as a borderline mucinous cystadenoma. Mucinous cystadenocarcinoma. This case was showing papillae as well as glandular configuration and was lined by cells composed of atypical cells with numerous atypical mitotic figures and nuclear stratification. Brenner's tumor. This case was showing nests of transitional epithelium surrounded by fibrous stroma, and it was reported as a benign Brenner's tumor. Benign cystic teratoma, the squamous epithelium with the underlying stroma. Yolk sac tumor. In this case, we can see the reticular pattern of cells lined by this. There is a cuboidal to flat cell lining the reticular or microcystic spaces. And this is the picture of a classic Schiller dual body seen in our case. Here we can see a central vessel surrounded by atypical cells, followed by a empty space, and again surrounding there is a lining of atypical cells. And this resembles the primitive yolk sac. Conclusions. Ovary is a common site of neoplasm in the female genital tract and presents with a variety of clinico-morphological and histological features. Histomorphologically, majority of the ovarian tumors are benign, and among the malignant tumors, surface epithelial is the commonest variety. Accurate diagnosis of ovarian tumors can be rendered in almost all of cases by correlating the clinical presentation, radiographic appearance, and histomorphological features, which remain the gold standard. Early diagnosis is crucial to decrease the morbidity and mortality among the patients, and so efforts must be made to identify the risk factors for malignancy. Thank you.
Thank you, Dr. Poonam. Thank you for a very detailed presentation. I think you were excellent. It was a pleasure listening to you. And now I would like to ask anybody for adding some comments or any questions if you have any queries. You're most welcome. So should we move to the next speaker now? Thank you, Dr. Poonam.
May I ask a question?
Dr. Farid, please.
Thank you very much for your lecture. It was very good. I want to know about endometrioid carcinoma. Didn't you have any endometrioid carcinoma in your cases?
Sir, in our study, we could not identify any endometrioid type of carcinoma.
I mean, is endometrioid carcinoma so rare in your country? Because it constitutes about something around 10% of ovarian masses, but I see that you didn't find any endometrioid carcinoma. Is it related to geographic variations or things like that?
Sir, as far as I have seen in my experience, we have a very few limited cases of endometrioid carcinoma that we have seen. And in my 3 year study that I had done, there was not a single case of endometrioid carcinoma. So maybe that is related to some geographical incidence of this disease. Or maybe some difficulty in diagnosing this tumor, as sometimes the serous papillary carcinoma can be difficult to differentiate from this tumor. And also due to lack of IHC, we weren't able to pick them up in our study.
It's impossible. Probably some of them are misclassified as serous carcinoma, probably, or other types of tumors, probably, I think. Thank you very much.
Thank you, sir.
Thank you, Dr. Farid. Thank you, Dr. Poonam.
Thank you, ma'am.
So, anybody else? So now we would like to move to our next speaker for today's session, that is Dr. Palak Poput from India. I welcome Dr. Palak, you for your speech, and I'm passing the stage to you.
Thank you so much, Dr. Jyotsna. Hi. Is my screen seen?
Yeah.
Am I audible?
Yeah.
Okay, thank you. So I am Dr. Palak. I come from India. I'm an associate professor in radiology in one of the most prestigious tertiary cancer hospitals in India, that's Tata Memorial Hospital. So today I'm here to give you an overview of breast imaging. This is the institute where I belong to. We have the Homi Bhabha block here, and we have our Golden Jubilee and Male Building blocks here. So before I was beginning to prepare for this lecture, I thought of penning down a few words which would focus on what we want and what we are talking about. And that is that books teach and teachers guide. They show the path to travel, but tread we must on our own accord. May darkness fall, but stumble we mustn't. The patient's hand, our guiding light, must we behold to navigate the treacherous path, each to her own, and walk down the journey, just her and us, to help her with the best for her best. We are groomed by our teachers and our mentors, but when it comes to sitting down with your patient, that's your world and you're left to navigate on your own. So that's where it's important to put everything that we've learned into one common pathway for your patient. So what is it that we radiologists do for the patient? We need to identify when to tell her not to worry. If she's normal, you should correctly identify that she's normal to go back home and assure her for the same. Tell her when she needs to come for follow-up. Tell her when you need her to walk with you and take you with her in a lot of other courses of investigations. Decide what to be biopsied and take adequate course for what's needed. Evaluate the patient thoroughly for any metastasis or any other problems. Assess for response to chemotherapy. Guide surgery for conservation versus mastectomy. Plan radiation. And once again, tell her when she's safe and not to worry, and keep her under close follow-up. So this is where we stand. So thus begins our journey of imaging in breast pathologies, a pivotal point for clinical assessment, pathology, and management. Various modalities in imaging form its stepping stones, and these are a mammography, an ultrasonography equipment, contrast-enhanced CT scan, magnetic resonance imaging, and image-guided intervention. Mammography. There are various types of mammograms. We have the film screen mammogram, which is two-dimensional. It could be a conventional film screen. It could be a computed radiography or a digital radiography. We have tomosynthesis, which is also called as a three-dimensional mammography. Contrast-enhanced mammography, which is new on the block. And the mammography can be of two types, either a screening or a diagnostic. We also have ultrasound, where we look at various features and parameters of an ultrasound equipment, that is a grayscale, color Doppler, elastography, automated breast ultrasound, and there is something called as contrast ultrasound, in which contrast can be injected, and we look at perfusion parameters on an ultrasound without any radiation or iodine issues. MRI, which helps us in morphological evaluation, as well as functional evaluation. The latter is essentially seen with diffusion weighted imaging and dynamic contrast kinetic curve imaging. These can be quantitative or qualitative. Computed tomography, we have a choice between either a contrast enhanced CT scan versus a PET CT, and this is primarily done for staging purpose and to look for response assessment. Intervention. So image-guided intervention comes through all the modalities that we discussed. We have mammograms where we can localize the lesions either by a hook wire. We can have stereotactic biopsies where either a core biopsy is taken or we can have vacuum-assisted biopsies. And we need to give special attention to specimen mammogram. So after a biopsy, the sample is put up on the mammographic unit and we take a shoot. And identification of the microcalcifications needs to be very accurate because you are going to be telling the surgeon whether to resect further margins or not. So that needs very careful attention, not just for seeing that the microcals are removed, but the entire area of calcifications is removed or not. Ultrasound interventions are, again, they help in localization, either by skin surface marking, which we call as sonolocalization, or it could be placing of a hook wire through an ultrasound. Biopsies can be done, again, which could be core or vacuum-assisted biopsies. MRI also, we have MRI-compatible hook wires for localizations and MRI-guided biopsies, which would always be vacuum-assisted biopsies. Therapeutic intervention offered can be in the form of a vacuum-assisted excision biopsy, in which there are certain indications and sizes below which this can be offered with near complete regression or resolution of the mass post-biopsy. Cryoablation is a new promising modality of treatment coming up for small 1 or less than 1 centimeter tumors. Microwave ablation, high-frequency ultrasound ablation, and radiofrequency ablation. These generally help in non-surgical, non-scar procedures. Interdisciplinary communication. So after understanding what all we have, what matters is how do we talk and how do we convey ourselves. It is very essential for what is in my mind to be conveyed to the surgeon or the physician exactly the way I am thinking. My language can be different, my choice of words can be different, and which is why for all of us to be on the same page, it is important that we have a good interdisciplinary communication by the common language. And this common language comes by having a standardized lexicon. So there are various utilities and options available. So like in North America, they would use the American College of Radiology, BIRADS, as a stratification, which is breast imaging, radiology, and data systems. And on the UK side, we have the Royal College of Radiology having their own press group lexicon, where they have a 5-point score system. So this is how the BIRADS interpretation reads. It's 0 to 6, where 0 is incomplete assessment and you want further investigation. Negative, benign, probably benign, suspicious of malignancy, highly suspicious of malignancy, and 6 is a known biopsy proven malignancy. And we do not include cytology proven cancers in a BIRAD 6. We still stratify them based on a 1 to 5. And 6 is reserved for generally for known biopsy proven cases. And you have essentially ruled out a multicentric or a contralateral disease. The RCR UK interpretation, however, is only included from a 1 to a 5 score. The difference between the UK and the BIRAD system is that the BIRAD system has a lexicon where it has descriptors. So the descriptors exactly define, have standard nomenclature and terminologies for each abnormality that is seen, whereas a lexicon is missing in the UK counterpart. So also, BIRAD stratifies with the percentage of malignancies or the likelihood that an abnormality detected is associated with a malignancy. So that is something which lacks with the UK side. So these may not be interpreted. But what matters is to have a common platform so that everybody is on the same page of understanding. And that's what I mean by saying what I am thinking needs to be conveyed to you without distortion. So this is just a snapshot of how the BIRADS card looks like. Currently, it is used for mammography, ultrasound, MRI, whereas the UK system also considers pathology to be a part of the 5-point sharing system and cytology. The current edition in BIRATS is the 5th edition, which is since 2013. And we can expect tomosynthesis and contrast enhanced digital mammography to play a greater role. And I don't know if they may be incorporated in future editions. So coming to mammography, talking about screening. So as I said, there are two types of mammographies. It's either screening or it is diagnostic. So when we talk of screening, we do not have screening in my country. There are screening programs running in various countries. So that is when the mammographic screening is enrolled within the government health system, and they are all registered, and the patients do go for a mammogram, and if they are not gone, they're called up and they're asked to report for a screening mammogram. Now, there are various countries have their own guidelines of the age of onset to begin with, the interval of how frequently it needs to be done, and up to what age you would want the lady to be screened. So usually the age of onset can be anywhere from 40 to 50, and it varies. Interval could be 1 year, 2 years, or 3 years, depending on the country that you are from. Up to what age, again, can be around 70, 71, 75, or by and large, you can consider that until the lady is likely to live 10 years of good, healthy life, she can undergo screening. So there, the age may not be a deterrent. So there are different guidelines, and this is how, globally, so these are the countries where we have an established screening in place across the globe. So if we see, that's quite a small percentage of the continents. So what I would say over here is the preventive task force in US would suggest a biennial screening from 50 to 74. And the American Cancer Society suggests a biennial screening, that is once in 2 years, from 45 to 54. In India, we do not have a screening guidelines. UK would follow a screening, say, every 3 years by the National Health System. Canada would be again 2 years. Australia is about 2 years. Canadian Task Force gives an option of 2 to 3 years. So it is all variable. In our country, so it's more of an opportunistic screening. If I decide to go and get a mammogram done tomorrow, I can go and get a mammogram done. So that's more like an opportunistic screening. And what I mean by a diagnostic screening is if I have a symptom or the physician has picked up some palpable abnormality and I walk in for a screening, then that's more of a diagnostic screening. So when I look at an opportunistic screening in my country, it would be something like 40 to 50 years would rather suggest a clinical breast examination. And after 50, biennial, that is 2-yearly follow-up, may be done after the age of 50 years. But this is not the national screening. This is when the patient goes to the doctor. So clinical breast examination is what I would say is far more feasible. When I showed you the global distribution of screening, it is in a very small proportion of patients across the world. So considering that, if it is not viable for a country to run a screening program, far more economically viable is to have a clinical breast examination in place, which is at no cost. It comes with experience, it comes with expertise, and having minimalistic training to the required medical health personnel and the paramedical health personnel, and to run this program across the country is the way to go for picking up many more significant cancers and dropping down the mortality versus screening. Because the other flip side of screening is you do detect a lot of small indolent cancers, which perhaps would have never grown. So best is to have a good clinical examination, breast examination in place, and that would be the game changer for dropping down the mortality associated with breast cancer. Just some further reading for certain screenings. So this is an article just published in Lancet on the impact of COVID-19, where nearly more than 50% is a hit in all the screening programs which have come to a halt across the globe, and especially for breast, cervix, and lung cancers. And this also tells us somewhere that we do need to look into strengthening our clinical breast examination. or no cost, the education and inclination towards it can actually help detect a lot of significant cancers. So coming to a mammogram in its interpretation, so what are the normal views like and what is the appearance? Okay, so so normally we have craniocaudal and MLO views taken for each breast. So that makes it like the 4 standard views. And the appearance may vary. So we have like a very fatty breast over here, predominantly fat. This is scattered fibroglandular parenchyma. This is heterogeneously dense fibroglandular parenchyma. And this is like a whitewashed breast, I would say extremely dense fibroglandular parenchyma. So there are certain descriptors and abnormalities that we see on a mammogram. So the commonest is a mass. The descriptors would be describing the margins of the mass, the shape of the mass, whether the shape is round or oval or irregular, how the margins are circumscribed or obscured, speculated, if there is any architectural distortion associated. So I will show that to you as we go through various images. The morphology of the mass is then deciphered as it's either benign or it is suspicious. So this is how we can have an abnormality which looks like a mass on a mammogram. This is a left breast, and the patterns that I showed you earlier were belonging to the right breast. So yes, there is an abnormality seen here. It is a mass. There are some partially circumscribed margins, but it is of irregular shape, and there are some internal lucencies. This is another example where I have a much more smaller mass, well circumscribed, it's oval in shape, and it is isodensely adjoining parenchyma. So that's how you describe a mass, its density, shape. This mass over here is of a high density. We look at the adjacent breast parenchyma. This is the left CC view, and this is the right CC view. And similarly, we have the left medial lateral oblique, the MLO view, and the left MLO view and the right MLO view. So we have this high density mass. It has speculated margins in some part of it, and there is some amount of architectural distortion. And there's another additional abnormality seen here and here. So this is just not the tumor. The tumor is also extending over here. And if this is not seen on ultrasound, she would need an MRI to look for multicentricity if she undergoes a breast conservation surgery and not a mastectomy. So evaluation is important. Coming to the other commonest abnormality seen, and that is calcifications. Calcifications can be, again, based on their descriptions, classified into morphologically benign or suspicious. So the morphology and the distribution are the 2 parameters that we see when we describe calcifications. The benign, this is a benign morphology calcifications and paths where we have nice calcifications seen within normal, well-formed ducts, and this is surely benign. And here we have some calcification in hyperplastic ducts where there is a single layer of hyperplastic cells seen here, again, no malignancy. How do these look on imaging? So when you look at imaging, there are various sites at which the calcifications originate. Skin calcifications look classically like this, and they are usually due to deposition in the sebaceous glands. Vascular calcification are along the vessel wall, and they can have a tram track appearance. Coarse or popcorn-like are typical calcified fibroadenomas. Large rod-like calcifications can be intraductal or in the ductal wall. So sometimes they may mimic a vascular calcification. Round calcifications are usually originating from the sinus or lobules. Rim calcifications are a peripheral thin rim of calcification, usually along a cyst. Dystrophic calcifications are seen at the site of fat necrosis, and they're curvy, linear, and arc-like calcifications. And milk of calcium are seen in distended terminal ductal lobular units, where they appear like a teacup calcification, as in a cup with a level of tea within. This is the appearance which is classically described in a dead lateral view. However, when we look at them in office, in a craniocaudal view, they're usually seen as a very dense center, high density in the center, and they are less dense along its periphery. So it's something like a halo, which I will show you as the case comes along. And sutural calcifications, where you have these calcifications along a suture site, and they're usually present in the stroma. So this is an example of these lucent center calcifications here. These calcifications on the magnification view Okay, so this is how they're exactly looking over here, very nice and lucent center. These are in the skin. Now, skin calcifications are not always going to be in the skin. They can also be along the skin when they are present in the anterior, upper, and the lower surface of the skin. That is when the projection happens through the parenchyma. These are examples of, again, lucent centered, you would say, but they are partially lucent centered. There is a thick rim around, and this another calcification seen here. These are classically cysts, which are undergoing calcification in its wall and the center, and these are calcifications of a cyst. This is an example of a calcifying fibroadenoma, where it is a dense chunk of calcification, which is occupying the area. These are vascular calcifications where you have tram track appearances, symmetric on both sides, which does not matter. We don't even mention these at times. This is just a close-up of one of them. Similar looking calcifications, but not vascular. These are rod secretory calcifications. Occasionally, we have such calcifications which may be seen in plasma cell mastitis when they are extreme in number and they have tapering ends or margins. But by and large, these are classical rod-shaped secretory calcifications. The lady does not need to come again. Here we have a lady who has a left mammogram. And if we look at her, there are some calcifications seen over here and very faintly seen in the central region and the lower region. So on the MLO view, this is the lower aspect. This is the upper aspect. And on the cranial caudal view, this is the outer aspect, the inner aspect, and this is the central region. So as we have a magnification view done here for these cases, we have these multiple, the kind of calcifications are described where there is a dense center and a little peripheral lucent area around. They somehow have these angular margins or rhomboid shapes. And then when a dead lateral view or a medial lateral view is taken, they classically flatten out. So a teacup calcification is when you have a nice cyst formed so that you can have a layering teacup. But most of the times, often these calcifications, they simply flatten out. And these are classical benign calcifications. So when we see this, we can convincingly tell the lady that she can go home and be on a regular surveillance and not needing further investigations. So time foretells and comparison is important. So something which may be probably benign can be observed, and the dystrophic calcifications, they often grow over time. And over 2 years, this lady's calcifications from here have grown into these, and these are classically benign. Coming to suspicious morphology. So we have calcifications here, and there is a lot of proliferative cell layer and some disruption of the myopithelial layer here. So let us see how these look on imaging. So we have amorphous, coarse heterogeneous, fine, pleomorphic, and linear, and fine linear branching calcifications, which make it a suspicious morphology. The distribution of calcifications is very important when we look at a mammogram, and that is directly linked to the probability of malignancy, just like the morphology. So we have these linear calcifications where they're arranged in a line. These are usually along a single duct. We have the diffuse calcifications on its other hand, where they are scattered nearly throughout the breast parenchyma. We have a regional distribution, which can be like around 2.5 centimeter square area. And we have a grouped area, which earlier were called as a cluster, and now they are called as a group of microcalcifications when you have them more than 5 microcalcifications in a small area of 1 centimeter square. Segmental microcalcifications are within an entire ductal lobular unit. So they are usually seen within a segment of a breast, and they usually form a pattern of or a triangular pattern with a base towards the periphery and with the apex towards the nipple, and they maintain that configuration between both the views. So BIRADS 1, we're all happy because there is no abnormality. The lady can safely go home. Coming to BIRADS 2 kind of calcifications. So the morphology and the distribution. Morphology, I showed you the calcifications which have a classically benign appearance, and distribution-wise, the diffuse round and the diffuse amorphous microcalcifications can be considered as benign. So what I would want to say here that when you do have such diffusely, loosely scattered calcifications, they can be given as BIRADS 2, and they're usually benign. Next is BIRATS 3, where we say they're probably benign, and the lady on a BIRATS 3 score is usually called back after 6 months, and we would want to see whether they have remained stable or not. And if at any point of time the abnormality worsens at the 6-month follow-up up to a period of 2 years, we can upgrade the finding to a BIRATS 4A and we target the lesion. If it remains stable after the end of 2 years, the abnormality can be put down to a BIRATS 2 and she can remain on regular routine surveillance. So here this lady, she has some microcalcification here and very faintly seen here. So we ask for additional views, and additional views for microcalcifications are usually in the form of magnification views. On the MAG view, there are these microcalcifications in a regional distribution, but they are nice, round, and monomorphic, all of them. So such a uniform pattern and fairly loosely distributed calcifications, we can call them as BIRATS 3, and she can remain on a follow-up. And she insisted on histopathology, so that was done, and it was all ductal hyperplasia and adenosis changes. BIRATS 4. So the calcifications that fit into this category are coarse heterogeneous, segmental distribution of round calcifications, amorphous, which is more like powdery type of calcifications, and fine pleomorphic calcifications. So these are the examples where you have these variable size microcalcifications. This is in a group. It is quite like a grouped microcalcification or a cluster, as I said. So that would shift to a BIRATS 4. Though the morphology is not so suspicious, the distribution would make it suspicious, fairly less though, and we undergo for a target localization. And she was on histopathology, she had all adenosis and fibrocystic changes. The other 4B findings are coarse heterogeneous calcifications, where they may be 0.5 to 1 millimeter. 15% of them may be associated with malignancies, so we look at them with caution. When they are multiple and bilateral, they may be considered as benign. If there is a single group, as I just showed, then it needs to be categorized as a BIRATS 4B. The other 4B variety is fine pleomorphic calcifications, which are usually less than 0.5 millimeters. One more 4B finding would be a segmental distribution. So when we see segmental distribution of calcifications, the calcification seen here, if we take a zoomed view, this is quite a segmental distribution as I was discussing. This distribution would make it make it worrisome, and it puts it under the category of 4B. A 4C is far more suspicious than a 4B. Now, a linear distribution or a branching linear calcification pattern would be considered as BIRATS 4C. This is a much more larger area of linear and branching microcalcifications. This would also be a 4C. Why a 4C and not a BIRATS 5? Because sometimes, occasionally, this pattern may be seen in sclerosing adenosis also. BIRATS 5 are got to be the linear branching pleomorphic microcalcifications. A segmental distribution may make it a BIRATS 5 in that pattern, and any new microcalcification of that variety would put it into a BIRATS 5. So pathologically, the lesions are usually now subtyped as luminal A, B, triple negative, and HER2 type, which are luminal A is when we have the ER and PR positives, HER2 may be negative. Luminal B is ER positive and or PR positive, HER2 is positive. Triple negative, all three are absent, and HER2 type is only HER2 fish amplified. So basically, the type of prognosis is best with luminal A, which are ER positive tumors, okay, and they're worse with triple negative breast tumors. So do we have a translation of the patterns in pathology being translated into imaging? So to some extent, yes, we do have them. So a hormone receptor positive often looks something like this. These are 3 different patients where we do see similarities of these high density masses. They have lobulated margins. They have some speculation, architectural distortion around it. Here, there is some speculation. There is some architectural distortion around it. And similarly over here, all these 3 patients were hormone receptor positive. The next set of patients that I will show you are HER2 positive patients, in which we have a similar looking mass, but on the magnification view, there are extensive microcalcifications seen there. This is another patient where the larger mass seen here is a metastatic node, and the entire disease lies over here as extensive calcifications. Look at this duct, which is entirely laden with microcalcifications, heavily burdened. This is another patient, a large mass, and we have a digitally zoomed image which shows extensive microcalcifications. So HER2 positive patients are known to have higher frequency of calcifications associated. Coming to triple negative breast cancers. So triple negative breast cancers are usually very well defined. Not always, but they can be. This is one nice well-defined tumor. It has a circumscribed margin, and which is partially obscured because of the parenchyma, otherwise very well seen. This is another tumor where it has a very nice circumscribed margin seen all along. And this is yet another patient with a fairly well circumscribed mass. So what matters here is that these masses can often show when they are smaller, they may appear like classical fibroadenomas, even on ultrasound. And a high caution and careful evaluation is hence necessary because these are aggressive tumors and these should not be mistaken for benign tumors. Like this one over here, though for the sheer size and density and the associated nodes, we would call it suspicious, but had this been small when it would have started to grow, it would have mimicked a benign lesion. And the books say that when we have something called as a halo, so this is a halo around the lesion. So a halo usually portends when it is more than 70-75%, it portends that it is going to be a benign lesion. But with triple negative breast cancers on the block, I'm afraid we may not be able to fulfill that criteria, and we need to continue to remain to be alerted for these findings. So there is this 42-year-old lady who presented with diffuse redness and swelling of the left breast. So what do we see here? We have these findings of a large mass in the left breast. There is a lot of trabecular thickening, which is interstitial thickening of the breast. Okay, there's a lot of skin thickening diffusely involving and also involving the nipple areolar complex, and there are microcalcifications. So this is a suspicious mass. Okay, she undergoes surgery. These are her extensive microcalcifications. This would be given a BIRATS 5, which is surely suspicious for malignancy. And she was a malignancy in invasive breast carcinoma. On the opposite side, she was on serial follow-up. And the follow-up mammogram showed that there were some new onset microcalcifications, which were seen here. And this was magnification view where they were seen better, and this is 1, 2, 3, 4, 5, 6, 7, 8. This would be a group of microcalcifications, making it suspicious. This was the position of the microcalcifications in the emido view. Seen in both the views, we could target with a hook wire localization, and the digitally zoomed image of this microcal was not very different from the previous one when you compare both of them. Hence, it was decided to target them. Good for the patient. These turned out to be, after the sampling, these were as benign changes, and she was good to go home. But yes, picking up that finding was important. It's because it was sitting on the fence. It could have tilted on either way. This is another lady, 46 years old again. She had a lump in the right breast with history of carcinoma breast in her older sister at the age of 29 years. So she was surely really worried. And when we look at her closely, on the contralateral side, we find these changes. So these were the changes seen, and they were classically benign. But did we need to target them? Yes, we did. Okay, so these changes, I don't know if they're well seen here. On the magnification view, they were well seen. They were all benign. There's just another 52-year-old lady who presented with a lemon-sized lump in the right breast. So she has this lump over here, and there are microcalcifications here. And this intermammary node is suspicious for sure. And there are some microcalcifications seen here. These are amorphous or powdery type of microcalcifications. And as we see them on a zoomed magnified image, they don't look typically benign, but they don't look typically malignant either. And these are again classical BIRATS 4. There is absolutely no density associated with it, but it is a tight regional involvement and it has to undergo histopathological correlation. And this was also benign changes. So it is essentially to pick up the right calcifications and put them under the microscope when they need to be. So now coming to next, that is contrast enhanced mammogram. And what is it? So contrast enhanced mammogram, we see it as a prospective modality, especially when an MRI is not feasible in patients, either because of time or cost or interpretation. So what happens in a contrast enhanced mammogram is like CT scan. The iodine dye is injected into the venous system, and images are taken, that is mammographic images are taken from 2 to 8 minutes after injection. So this is a left-sided mammogram where we obviously see a pathology over here in the central view. And this is a contrast enhanced mammogram in which there is uptake of contrast seen in both the views. So this very well highlights the pathology against a background, and all the rest of the parenchyma is subtracted digitally from its mask image. How it helps? So this is another patient where she has large axillary nodes of unknown origin, and the breast parenchyma is essentially normal. And what we do find is diffuse skin thickening, which could either be because of a tumor in the breast, or it can be because of secondary edema coming in from blocked lymphatics because of the large axillary nodes. So when we have that, we need to find any occult primary lesion or a distant site of primary with metastasis to the axilla. A contrast enhanced mammo done for her shows a very well distinct area of non-mass enhancement in her upper region, and that was the primary focus of tumor. So that's the beauty of contrast mammo, where there was absolutely no sign of having a pathology here, except for some architectural distortion seen retrospectively here, but it was not seen earlier. So the next modality that we see is an ultrasound. So ultrasound, we have various modes of ultrasound. We have the B mode, which is a grayscale, in which we see lesions like this. So here we have hypoechoic lesions or blacker lesions. So hypoechoic is hypo or darker compared to the surrounding parenchyma. We have color Doppler, where the vascularity of a lesion is assessed. We have elastography, where the stiffness of lesion is assessed. So this is on the basis that a stiffer lesion will have a darker representation. So of course, the scale can be changed. And based on that, you can have a soft or a hard lesion being delineated. So this lesion is essentially a mix of green and blue, which would mean intermediate stiffness, but tending more towards being on a higher side of stiffness. It does not always help you in clinching down the diagnosis, but it is just an assistant that gives you some more insight into the morphology of the lesion. So whether in ultrasound, I would look at as complementary or supplementary. So I best put ultrasound as it is a supplementary investigation done after a mammogram for any pathology picked up, and it is complementary to the mammogram for your final report assessment. So the final BIRATS category given to a lesion is after the ultrasound interpretation, even as per the new BIRATS system. So it is an integral part of your assessment. So for example, as I showed you this mass earlier seen on the mammogram, I'll show you the ultrasound image for it. This is the ultrasound. There is no mass over here. All that I'm seeing is dense fibroglandular parenchyma, dense parenchyma, which is interspersed with fat. So what happens is when you have such dense islands of parenchyma, they have these pseudo borders. The borders become so sharp and so distinct that they start giving you margins on a mammogram. So whatever you see and however abnormal or normal you think is a mammogram, it must be subjected to an ultrasound for better delineation. And something like what the other lesion that I showed you here, this is very classically seen on ultrasound. This is a nice, wider than tall lesion with some posterior acoustic enhancement. There is some shadowing along the lateral margin. And this is how a classical fibroadenoma looks like. And we have the marker for assessing the position mapping of the lesion for future reference. So this mammogram and ultrasound itself is sufficient, and we do not need to tell the patient to come on any close follow-up either, and she's a BIRATS category 2. This is another example of a high density mass with obscure margins and an ultrasound. This is a darker lesion. It has microlobulated margins, which are a telltale sign of probability of malignancy. It is much more taller than being wide and some amount of shadowing. This is a heterogeneous posterior shadowing. So this mass would be suspicious, and this will be a BIRATS category 4C. And obviously it would require a biopsy sampling. Now, this lady, just 53 years old, she was worried about some nipple discharge from her left breast. The mammogram just simply tells us that there is some vague density here and some coarse calcifications. Calcifications do look benign, but any nipple discharge, it has to be evaluated with an ultrasound. And on the ultrasound, the abnormal duct was well seen, and we could see the density as a dilatation of a duct, and the calcifications were also seen inside. And this is such a homogeneous echogenic tissue within that it did favor a benign appearance of the duct. However, because she was really concerned, she did undergo surgical sonolocalized excision, and it was all fibrocystic change with a papilloma. So that's how an ultrasound adds to your mammographic interpretation. This is a young girl, just 23, and she had a palpable mass near the nipple, and she was advised for a mammogram. Though had she come to us directly, we would have first done an ultrasound for her because of her age. But she came with this mammogram outside, and we see this mass and this calcification here. The ultrasound picture is very classical of some internal necrotic calcific change, or it could be a papillary lesion, but because of a possibility of some benign fluid cleft-like appearance, a phylloids had to be ruled out on this kind of an image. She did undergo histopathology, and it was a fibroadenoma with few patch-like areas, which is pseudoangiomatous stromal hyperplasia. Now, another technique of obtaining an ultrasound is ABUS, which is automated breast ultrasound, in which the lady is made to lie down prone on a table like this. The breasts are hanging down into dedicated cups, which is quite like a position for a breast MR. So we have used some of these images, and by our experience, this is a very good modality when you do not have sufficient radiologists, or there is a dearth of dedicated technologists, and patients still need to be screened. So then it is good because it reduces the manpower. But having compared a lot of cases, it does not overcome the need of a handheld ultrasound, and there are satellite lesions which can be missed. So it is good for having a screening in place. But when a pathology is seen and you want to look at satellite lesions, I would say that a handheld ultrasound should be done for better mapping of disease and characterization of findings. Coming to an MRI. So MRI would generally be indicated for screening high-risk women and for surveillance, like BRCA positive patients every annual, they undergo annual MRs and annual mammograms at 6-monthly interval. Then we have occult primary breast cancer to be detected. So like axillary nodes are seen, and you want to see if there is any other mammographically or sonographically occult breast cancer. Preoperative staging and determining multicentricity, multifocality, especially I would say that for lobular carcinomas, an MRI is often a game changer in planning treatment for the patients, and it must be advocated. Chemotherapy response assessment, it is subjective, it is not a standard of care across countries. Post-lumpectomy residual disease, if margins are positive, and to know the extent sometimes, it helps. It does not replace a mammogram. Mammogram will tell you microcalcifications, and the functional enhancement can come by a contrast mammo or an MRI. So they are complementary imaging techniques. Implant evaluation, ultrasound and MRI are available, but still MRI does score over an ultrasound. So I'll just take you through a case of a young lady, 59, with history of lump in the right breast. Yes, she would be young. With history of lump in the right breast since about 6 months. So yes, we do find some pathology here, something here. And she had undergone some small surgery in the past on the left side. There are some calcifications here and over here. So we have bilateral calcifications. Okay, and this is the MLO view. They're seen very well over here. The magnification view of these calcifications shows them as groups of coarse heterogeneous calcifications along the central region of the nipple, and very fine speculations are seen extending across, and we see a segmental kind of a distribution towards the nipple for these calcifications. And on histopathology, there was, yes, I think this is the histopathology of the report that she had undergone earlier. I'll come down to that. So this is the MRI that she underwent, and the speculations that we were seeing, that area was very well enhanced over here on the MRI. This is a subtracted MRI image, and there's something happening on the contralateral side. And there was a small focus which exactly behaves like the lesion over here that we see. So this is one area, and there was something on the opposite side. And this is at the level of the heart. And we have ROI. These are curves that are drawn, and you look at the kinetics. So this is the contrast being washed in and being washed out. So you look at enhancement characteristics of the contrast, and when you have a rapid wash in and a rapid washout, it is likely to be a malignancy. This had a fair kind of a delayed washout, I would say, not persistent, but not a rapid washout, which tells that this is a malignancy. Another focus was seen much superiorly at the level of the aortic arch. So this lady had bilateral, at least 3 to 4 identified foci of tumors, and not all of them had characteristic washing washout. This one is washing in really late with delayed washout. And the histopathology for this patient was the lobular carcinoma, which the slide got misplaced. So meaning to say that on MRI, if we talk of wash in and wash out and the type of curves and the morphology, it is a lobular cancer always defies the rules. Okay, so lobular cancers, when suspected or when on histopath, you have one side as a lobular cancer, even if the curves are not suggestive of, or if the morphology is different, suspicion of having a lobular neoplasia is very high when we do an MRI. Right, coming to contrast enhanced CT scans. So CT scans are usually done for metastatic staging, like we have these multiple mets here in the liver, and we can also see a abutting pleural nodule in the lung over here. So whether to do a ECT or whether to do a PET CT is, it varies as a practice across various parts and various countries of the world, but we often see contrast enhanced CTs giving a fair accuracy of the staging of the patient. Image guided intervention, we have hook wire localization. So this lady who came in Feb last year with a lump in the left breast, and then she came for re-evaluation right in the first week of lockdown of COVID, and she wailed, and she was insisting that she only wanted a BCT, and that is a conserving surgery and not a mastectomy. So when we look at her, and then she's come again, so we have this pathology over here. So what do? She wants a BCT. Can we do a BCT? There is a whole lot of abnormality here and here. So you map the disease, you put a nipple pectoral line, okay, in both the views, and measure your distances and see how the disease is. This was a segmental distribution as shown, but there were multiple calcifications seen everywhere. So she wanted a BCT. So what we did so this would have been amenable to a conservation surgery. But if these are malignant, she cannot undergo conservation. And she had such foci. If you see, there were multiple foci in both the breasts. So now what do we do? And how do we go ahead? So we looked at the worst focus, which was at the furthest distance on the ipsilateral site. And since it was, when you have many foci, you cannot pinpoint and say what is seen on the CC corresponds to something else in the MLO view. So that's when tomosynthesis helps, and you pick up the worst calcification seen in a view, and you use tomosynthesis to exactly go in that calcification in that view. And that's what we did. So this was a furthest group of calcification. This was way inferior, whereas our calcifications were superior. So we picked this, and this was targeted with a hook wire under tomosynthesis. And contralateral, we took up the worst looking microcalcification, though it was not looking very suspicious, but we had to be sure because she was undergoing surgery. And this was also targeted by a hook wire localization under tomosynthesis. And the histopathology said that after the left breast, she did undergo obesity. The mammolect localized excision on the left side, which was the lowermost point, was also malignancy. So she underwent a second stage mastectomy at that site. And on the contralateral side, it was all benign changes for her. And so she's kept on observation and follow up. The other interventions we have are stereotactic vacuum assisted biopsies. So this is how the biopsy unit is seen. We have the patient seated here, and this is our mammographic equipment along with the stereotactic biopsy unit, and the needle is entered from the superior aspect. And these are the microcalcifications that were being targeted for her. We target them with the probe is passed through. This is the trough of the probe, which is in the center place to the microcalcifications. And these are the cores, and these are nice volume of cores, which a pathologist often is happier with than the smaller 14 gauge cores. And these are the calcifications which luckily in this patient were so well seen even otherwise. So that tells you the success of these procedures, and these have to undergo a specimen mammogram. So talking of on the last aspect of my talk is how do you make an impact on the management? So now like this lady, she has a right mammogram. Well, she has an obviously looking pathology over here. There is this high density mass with some architectural distortion. If I carefully look, there is some microcalcification extending posteriorly also. So can the surgeon remove only this much for conserving her breast? No, it is my job to pick up these calcifications here, and my job does not end there. I have to look at the rest of the breast. And when I do that, I see something here, I see something here. And having a closer look, this is a linear distribution of microcalcification. Now, had this and this been removed with a BCT, the lady would have still had active disease left out. So as a management, when you discuss about the areas and of pathology, the extent must be given. So for example, this lady, you must give the extent of this microcal from the index lesion and its distance from the nipple areolar complex to make the surgical mapping more accurate. So now, for example, this lady, she seemed to have microcals over here, but there were microcals all around over here also. So we have disease in 1, 2, and 3 quadrants, which would say that she should undergo a mastectomy, but does she? No, not necessarily. So we have to evaluate her very well. So when we see microcalcifications here, and this is a zoomed view, so how do I go by evaluating her? We draw a horizontal PNL line, nipple posterior pectoral line, and then I see the extent of microcalcification. So in the CC view, this is outer and this is inner. So I will measure the distance of microcals going on the outer side and its extent on the inner side coming all the way through. And similarly, on the MLO view, how much of it is superior? Well, there isn't, and how much of it is inferior? And then translating that into a digital kind of an image and a pictogram, it tells me it is just below the nipple, it is extending a little bit on the medial side, and it is extending inferiorly. So this tells that this patient is amenable to a breast conservation surgery. So what looks so ghastly on a mammogram may not be that extensive a disease. So you have to step in at the right time to tell the surgeon to resect more or to tell the surgeon to resect less. And that is where a radiologist becomes a pivotal point for management of the patient. So my pearls would be that we must know the options of the modalities in imaging in detail. History is to be well taken. Choose your modality wisely. We must have a mental algorithm of what should be done next in the order that is appropriate. Target the most appropriate lesion. Achieve good volume for sampling. Always discuss with oncological team and the pathologist, and never stop exploring. So I would like to end my presentation here, and I would thank you for listening to me as we strive together to refine ourselves in this journey of quest for performing better for each successive patient. Thank you so much. I would like to take questions if any.
Thank you, Dr. Palak, for a very comprehensive, detailed presentation. It was really very informative. Like, I am also wiser as a pathologist now to read more mammography in future. So anybody who wants to ask something or add something? I would like to say here, Dr. Palak, that like you stressed on clinical breast examination. So in our setup, I think we should stress on self-palpation also and make ladies aware about this and take the help of health workers, because I have seen many patients like coming late with advanced stage just because they hesitate to reach out to a doctor because they have so many apprehensions about this breast carcinoma. So I think self-examination they can also be made aware about this using many like media, health workers.
Yes,
Would you
absolutely.
agree?
That is something which we also emphasize on all the while. And another added dimension to it is the texture, I would say, of palpation of each breast is different for a lady. So, and it varies with every menstrual cycle of her. So, if we educate our women that you palpate yourself, and she knows how her breast is, and she will be the first to detect a pathology when she knows how her breasts are. So she can be better than some medical officers also. So yes, it is a very important point, and we are trying to move towards that education.
Thank you, Dr. Patel, for an
Thank you so
excellent
much.
comprehensive presentation. So I think we should move on to the next presentation now. You have no
Sure.
questions. You were so clear with your presentation.
Thank you. My pleasure. Thank you so much.
Thank you. So now I take this opportunity to welcome our next speaker, Dr. Sana Garmani from Morocco, with her speech. Welcome, Dr. Sana. Over to you.
Okay, thank you. So good morning, everyone. I'm Gamrami Sana, PhD student at Department of Pathology here, Hassan II University Hospital, Fez in Morocco, and also Medical Center of Biomedical and Translational Research, Faculty of Medicine and Pharmacy. And today I'm presenting my study made in our laboratory titled Chromosome 17 copy number gain. Can I click this? Sorry. Chromosome 17 copy number gain correlation of 20 cases with clinical pathological parameters and HER2 gene amplification, an experience from a single institute under the direction of Professor Henry Fatmi, a professor, a highly qualified professor in breast cancer pathology. So, the epidermal growth factor is located on chromosome 17 and a member of epidermal growth factor OGFR family, and is responsible to cell-cell or cell-stroma communication by his tyrosine kinase. Also, HER2 gene acts as proto-oncogene involved in invasive apoptosis and modulation proliferation. The HER2 protein overexpression is direct origin of the HER2 gene amplification, and its presence in approximately 90% of all breast cancers. Also, the HER2 gene amplification frequencies range from 15 to 20% of all breast cancers. HER2 positivity is associated with poor prognosis marker, aggressive disease, and decreased survival. That's why determination of HER2 status is now an important daily practice in pathology. Except that, while interpreting HER2 fish, a copy number gain of chromosome enumeration probe targeting the centromere 17 is often observed. The polysomy of chromosome 17 has been reported in 10 to 50% of breast cancer, depending on the study population, tumor selection criteria, and definition of polysomy. Studies have indicates that the presence of polysomy 17 is correlated with the tumor aggressiveness and hormonal status, including histological grade, high nuclear atypia, lymphovascular invasive, and lymph node metastasis. Estrogen and progesterone receptor negativity. So, although HER2 overexpression is associated with aggressive behavior of breast cancer, clinical prevalence of chromosome 17 polysomy is still unclear. It has been hypothesized that an increased chromosome 17 copy number without true HER2 gene amplification may be explained by a small percentage of breast carcinoma with HER2 protein overexpression. Immunohistochemistry is widely applied as the first-line HER2 diagnosis, and then comes the FISH as an even more robust technique globally applied for HER2 atypical cases in formalin-fixed and paraffin-embedded tumor tissue specimens. That's why in our study, we aim to highlight the clinical pathological significant chromosome of the chromosome 17 polysomy. That's why we made a retrospective study in our laboratory with 208 cases of primary breast cancer on a period of 6 years from 2012 to 2018 at our laboratory of anatomy pathology of Hassan II University Hospital in Fez, which is the histological analysis was made in routine on formalin fixed and paraffin embedded tissue with hematoxylin eosin saffron staining, and the histological analysis was established according to Northingham histological score. And then comes the immunohistochemistry analysis, which is performed in parallel with estrogen receptor, progesterone receptor, and Ki67 as part of routine at our laboratory. At the end, the FISH analysis was performed on the parallel section from the same blocks as for immunohistochemistry. So, immunohistochemical staining was performed on 4 micrometer thick section mounted on stabilized microscopic slides from the breast primary tumors using primary antibodies according to the manufacturer's guideline with immunohistochemical stainer Ventana benchmark at our laboratory. For all antibodies, positive and negative controls were routinely performed, including processing of normal tissue and tumor section. The FISH analysis. In our lab, the FISH assays was performed using PathVision HER2 DNA probe kit with 2 fluorophore lablet DNA probes, permitting simultaneous HER2 and chromosome 17 gene copy number. Green signal in the nucleus identified 2 of chromosome 17. Red nuclear signal showed HER2 gene. When the HER2 chromosome ratio is more than 2 or more than 4 copies of red signal in nucleus are detected, then we say that HER2 gene is overexpressed. The statistical analysis was made using SPSS 21 statistical software. We evaluate the clinical pathological characteristic of our theory using chi-square test and Fisher exact test as appropriate. The survival curves were performed using the Kaplan-Meier method and Cox regression to evaluate the prognosis impact. The tests were statistically significant when P is under 0.05. For the results, in our cohort of 208 cases of primary breast cancer analyzed by FISH, 20% of cases had gene amplification, while 80% were non-amplified for HER2 gene. Then, a total of 20 cases, which is 9% cases, showed the presence of polysomy. The absence of polysomy 17 was seen in the remaining 188 cases. And then we performed a subgroup analysis in which we classify polysomy and non-polysomy according to HER2 gene expression. Then the 20 cases of polysomy presents 30% of polysomy cases with amplified HER2, and then 20 cases, 70% of polysomy cases were HER2 gene non-amplified. The remaining 188 cases of non-polysomy shows 90% of amplified HER2 and 81% of non-amplified HER2. Polysomy 17 in our study is showed more often in positive hormonal receptors and high Ki67 proliferation index. Those are illustrations from our immunochemical technique performed in our laboratory, showed a high expression of ER, PR, and high expression of Ki67. Then we proceed to a correlation between clinical pathological characteristic and chromosome 17 copy number gain which showed a significant association with various poor histological parameters such as low H, low mitotic score, high nuclear polymorphism score, high histological grade, presence of node metastasis, and not otherwise specific histological. Except that we think that this finding may be explained by the close relation between the HER2 amplification and chromosome 17 copy number gain. That's why we performed a subgroup analysis in which we correlate between the same clinical pathological characteristic, but this time with non-amplified HER2 polysomy 17. The HER2 non-amplified gene associated to polysomy 17 was significantly correlated with almost the same aggressive histological variable: low H, low mitotic score, high nuclear polymorphism score, high histological grade, not otherwise specific histological type, and also the presence of node metastasis. The evolution of the patient was studied retrospectively over the whole period studied. We evaluated the polysomy 17 HER2 gene impact on disease-free survival and overall survival of breast cancer subtypes this time. And then the polysomy 17 was significantly associated with decreased disease-free survival only in luminal HER2 negative. The proportion of polysomy 17 HER2 gene in our study is 9%, similar to the reported incidence of polysomy 17 in breast cancer by various studies. A review article says that the frequencies of polysomy 17 range from 3% to 36% of all breast cancer diagnosed breast cancers. Then, in our study, polysomy 17 was observed more often in the HER2 non-amplified than HER2 amplified cases. The same results were revealed by Osaria and al. We have demonstrated that invasive breast carcinoma with polysomy 17 is associated with several prognosis parameters, including this finding is this finding was similar to those with those made by UMA, which shows that prognosis parameters include low H, low mitotic score, high histological grade, presence of node metastasis, and also histological type, non-specific histological type. In HER2 negative subgroup, the polysomy was more often showed in hormone receptor positivity, but without no real significant association. In contrary, Osaria and all showed a significant association of progesterone receptor negativity with polysomy 17. In HER2 negative subgroup, the chromosome 17 copy number gain show a significant association with low age. And the other parameters. Osaria and all and other studies supports our results, which showed that there is a significant association of polysomy 17 with poor prognosis indicator. And we showed also that chromosome 17 number gain was clearly associated to decreased free survival in only luminal HER2 gene negative. Similar results were showed previously. Patient with chromosome 17 gain tumors in luminal B had intermediate survival in HER2 negative and HER2 innovation. So at the end, we identified 9% of cases of polysomy 17. We revealed that the polysomy 17 can serve as a poor prognosis marker in invasive breast carcinoma. And also, we highlight the prognosis value of polysomy 17 in luminal HER2 negative. So the perspective, can polysomy 17 serve as prognosis factor for the non-amplified HER2 gene? And thank you for your assistance.
Thank you, Dr. Sana. Thank you for your presentation. I welcome any queries from the delegates. Want to ask any question or add something to this?
Okay.
So, Dr. Sana, no questions. Thank you for your presentation.
You're welcome. Thank you.
Thank you. Now, I welcome Dr. Elizabeth Erameva from Russia with her presentation to deliver her speech.
Ну, что? Все? Открою и туда отвечу. Вот какая там пока. Dear colleagues, my name is Елизавета Еремеева. I'm a pathologist at Botkin City Hospital, Moscow. I would like to say thanks all organizers for opportunity to participate at the conference. And today I would like to tell you about very interesting clinical case metastasis of non-pigmented melanoma of the breast. Melanoma is one of the most aggressive and highly metastatic types of cancer that arises from the melanocyte and dendritic cells located above all in the basal layer of the skin. And what we know about our localization of melanoma. It's the eye, the mucus of upper respiratory tract, the gastrointestinal tract, and normal lymph nodes. As you can see on this slide, the most common localization melanoma metastases are the lung, liver, soft tissue, brain, and skin of various localization, up to 75%. The most rare localization are the gastrointestinal tract and the breast, up to 2%. It is necessary to differentiate the metastasis of melanoma with the primary breast tumors. And what we know about breast melanoma? There are 4 possible types of tumor: primary breast melanoma, metastatic melanoma over breast tissue, primary melanoma over breast skin, and metastatic melanoma over breast skin. It is important to differentiate this condition because the patient's management tactics may change. In primary tumors, surgical removal is possible, and in metastatic lesions, treatment can be started with radiation or immunotherapy. In ultrasound examination, the melanoma is represented by formation with clear margins, usually of a round shape. It often mimics benign breast tumor. For example, fibroadenoma has a similar appearance, a smooth contour, and a homogeneous structure. However, these changes are well differentiated from breast cancer, in which the contour is indistinct, the structure of the node is heterogeneous. In histological examination, melanoma is represented by solid fields of epithelial cells, but variants of spindle cells melanoma are possible. Mitosis are common. Breast cancer can be represented by solid, tubular, or cribrosis structure, or in this picture with micropapillary component. Necrosis is possible. Variable lymphoid infiltration. For differentiate diagnosis, we are assisted by IHC. In melanoma, the expression of S100, melan A, and NTB45 is noted. In breast cancer, these markers are negative. There are positive expression of CK7, GATA3, and estrogen receptor, but expression of estrogen receptor may be variable. For example, in the non-luminal types, the expression of estrogen receptor may be absent. And we report a case metastasis non-pigmented melanoma to the breast from skin. A 36-year-old female with complaints about the presence of a palpable tumor formation in the left breast. Okay, let's go back to the benign beginning of the disease in 2017. The first, in 2017, a surgical excision of skin formation of the right thigh was performed with simultaneous regional lymph node dissection. Histological examination revealed the diagnosis of epithelial cells pigmented melanoma of the skin without metastatic lesions in the regional lymph nodes PT2B and 0M0. Since November 2017, IFN adjuvant therapy was being performed. A molecular study revealed a mutation in the BRAF gene. Later, against the background of ongoing therapy in December 2017, She independently discovered an increase in the inguinal lymph nodes on the right. A puncture biopsy of the lymph node was performed. Cytological examination revealed metastasis of melanoma. From December 2017, DLT was performed on the grown area in the right. At the end of December 2017, an inguinal femoral lymphadenectomy was performed on the right. In January 2021, PET-CT revealed since March 2018, a combination therapy has been carried out. In January 2018, PET-CT showed multiple metabolic activity formation in the subcutaneous fat of the upper and lower extremities, lumbar and gluteal regions. Immunotherapy was performed. 22 immunotherapy injections were performed against the background of immunotherapy positive dynamics. After this therapy, we found complete response. The patient was under dynamic observation for 1 year. PET-CT from May 2020 revealed a soft tissue lesions in the S6 of the right lung. In September 2020, a typical resection of the lung segment was performed with histological examination of metastasis of pigmented melanoma. Adjuvant therapy was initiated for 1 year. And return to the 2021. In January 2021, PET-CT revealed a rounded formation up to 8 millimeters at the border of the lower quadrant of the left breast. A core biopsy was performed, histological examination of melanoma metastasis. IHC study of S100, Melan A and HMV45 expression was performed. Expression of estrogen receptor, CK7, memeglobin, GATA3, and progesterone receptor was negative. In ultrasound examination, the focus is represented by round, homogeneous, clearly margined tumor in the thickness of the breast tissue. In February 2021, a sectoral breast resection with simultaneous mammoplasty was performed. Growth on this dissection, we found rounding, soft elastic node with clear margins, white to gray color, while the skin above the tumor is not changed. There is no redness, pigmentation, retraction, or the appearance of lemon peel. In histological, the tumor is represented by solid fields of epithelial cells with the presence of multiple mitosis and weak lymphocytic infiltration. By the IHC study, there is no expression of CK7 and estrogen receptors in the tumor cells. There are a positive expression of HMB45 and Melan A in the tumor cells. In these images, you can see the membrane expression of HMB45 and Melan A. Taking into account the clinical, morphological, and IHC date, the diagnosis was made metastasis of non-pigmented epithelial cells melanoma to the breast from skin. The patient's condition is satisfactory. The patient was discharged under dynamic observation. In our practice, since 2010, the third case of a secondary tumor of the breast, when reviewing about 8,000 breast biopsies. It was the first case metastasis melanoma to the breast. Thank you for your attention.
Yeah, thank you, Dr. Ramira, thank you for a very wonderful and rare case presentation. It was very interesting. So, anybody wants to ask something? So let's thank you, Dr. Ramira. Thank you for having
Thank
me
you.
here. And now I welcome Dr. Nazir Khan from Pakistan for his presentation.
Oh,
Dr. Nazir, please unmute yourself.
Hello.
Hello, Dr. Nazir, welcome. You can continue.
Can you see my presentation on the screen?
No, you have not shared your screen as yet.
Let me. Share screen. Yes.
Screen sharing, the option is available at the bottom in the green color. Yeah.
Now.
Yeah, now it is visible.
Okay. It's okay now.
Yes, it's okay now.
Sorry for inconvenience. Hello, everybody. Good morning. Not. I think it's noon there. Good afternoon to all of you. Very pleased to join this conference, and probably I'm the junior most in this all meeting. Very nice to listen these lectures and to get some information. Thanks to all of you. Today in this conference, I'm going to presentation on the topic better reporting and awareness campaign needed for the breast cancer in Pakistani women, as the title is there in front of you. So before that, I would like to introduce myself. I'm a PhD student in the molecular cancer biology, and followed by the MS in molecular and clinical physiology from Pakistan. And these days I'm doing PhD in China. So nice to hear in between the all mind of biology from all over the world. So let's begin my presentation here. My work to present, actually, I publish a perspective in the cancer management and research in the medical press. The same topic as presentation, the better reporting awareness campaign needed for breast cancer in Pakistani women. Before to start my first presentation on statistics, I would like to say some words about cancer. As you know, the cancer at the present time is the most hateful word in this era. And many of us have lost family, colleague, loved ones, brothers, sisters. Every house has experienced this deadly disease called cancer. So as per statistic, according to the recent press release by International Agency of Research on Cancer, it is estimated that the burden is estimated to have risen 19.3 million new cases and 10 million deaths. And similarly, one in five people worldwide develop cancer during their lifetime, and 8 in men and 11 women die from cancer disease. Breast cancer is the most leading cancer, and which, as per the record of 2018, 2.1 million new cases were reported with 6 to 17,000 deaths has been reported. These updated global cancer burden figures highlighted the diverse cancer pattern, and there is a expected to rise in the cancer burden over the next decades. What can we do? Being a biologist and being looking forward this dangerous rise in number, so we can say what we can do is the prevention as the key role to play. Key to cure cancer is early diagnosis. We can only cure cancer by slowing its rate, not to cure it preventively. Although we can say cancer is a biological phenomenon, so we only can cure the cancer by delaying it, by diagnosing at early stage. If one diagnoses at cancer at early stage, there are greater chances to recover and survival, but diagnosing at later stages lower the chances of survival. So the background and cause driving force behind this paper, and 2 years back in summer, 2 years back in summer, my family passed through a great loss of my father's sister, Kaniz Bibi, who diagnosed the breast cancer 3 and died in June 2019. Here she is. We were in the front of hospital after chemotherapy, and she looked so black. You can see a contrast, skin color, and although she looked very happy, but she diagnosed she has breast cancer, 3-stage cancer. Being because in last 19 I was enrolled as a PhD student. It was my first year, and how I was getting the scenario and family history. I belong to a very rural area of Pakistan, and I summarize the condition and how to say a clinical profile of my father's sisters. There are some factors behind this. I can say she has very low health knowledge. Although literacy rate is low, she is not too much high educated, but of course, low health knowledge. She ignored the breast lump. As we all know, the breast lumps are painless, and she just ignored. And she didn't visit any nearby clinic, and she didn't go for mammogram test, and wasted much of time in spiritual and other local treatments. Many of you know how different rural societies and semi-urban societies are engaged with those spiritual treatment from religious peer or something. She was engaged with spiritual and other local treatments. And at the end, when time it come and she diagnosed the stage 3 breast cancer. So it was the driving force for me to summarize these conditions and starting to reviewing the literature, published literature, started to talk with my mentors, what's going on, started to talk with my clinical oncologist friend and my friend that what is this? And then I come to Google Scholar and starting to read the paper about the burden of breast cancer in my country. Of course, it was much shocking for me when I come to fact that my country is has a huge number of breast cancer patients, not only my father's sister. So here is the profile of breast cancer in Pakistan. Pakistan has the highest incidence of breast cancer, and in Asian country, Pakistan has the highest incidence of breast cancer as like our neighbor India and Qatar in Middle East, where 1 in every 9 women have lifetime risk to be diagnosed with breast cancer by the reason of, there are a number of reasons, by the reason of misconception about the etiology of disease, socioeconomic factors, and the system level constraint. Pakistani women have very low rate of early detection and diagnosed breast cancer at advanced stages with fewer chances of survival. Of course, it was very painful for everyone but these are facts. We cannot ignore the statistics as the published literatures. What is the aim? The key to cure the cancer is early diagnosis. The aim of the current study is to highlight the factor leading to delay in early presentation of breast cancer and to summarize the possible recommendation for educating the woman, early diagnosis along with palliative care facility for patients suffering from breast cancer. Study also appealed to both the general public and government in the belief that the better reporting and awareness campaign may bring more women to clinic for early diagnosis. Causes for increased burden of breast cancer in Pakistan. Why it's so? Why we are ignoring why this burden is increasing? So the causing of this increasing burden in Pakistan can be categorized into three main leading factors. These three leading factors are that patient level factors, behind, first from system level constraint and uh, clinical factor, the main leading factor is the patient level factors. Next is the system level factors when it comes to the hospital, oncologist, others. And third one is the clinical genetic level factors. So here we discuss all these factors. Patient level factors. When we ask about what are the patient level factor in Pakistan about the increase in high burden of breast cancer. So 5 leading factors from patient and that lead to delay in early diagnosis of breast cancer in Pakistan. First one, as I mentioned in my father sister's profile, there is a low health literacy. Pakistan has overall literacy rate of 5.2 something, 52% of literacy rate. But when we come to say about health knowledge, health literacy is very low, especially in the rural areas. Women do not know about too much about their disease, about other chronic disease, and some like for other leading disease in the society. So the first main reason as a low health literacy rate in the women in Pakistan. Second one is negative social perception about breast cancer. What means negative social perception about breast cancer? It means in the society there are number of social perception, misconception. People says that uh, cancer may transfer from patient person to person. If one person see the cancer patient, that cancer can transfer to another patient. Even there is a thought that is published facts. I cited in my paper. If someone see the breast cancer patient, he may get the breast cancer. Similarly, woman having breast cancer can transfer disease to his newborn. And similarly, if a woman have breast cancer, his family will pass through a number of many sorrows and hardship throughout the time, and so many. Next one is consider breast illness as a social stigma. If a woman has not only breast cancer, some other breast related disease, she thought that uh, it is a very harmful for me, and I will not be get married, and people starting to hate me. So she's starting to hide this problem, and she didn't tell to any other family members and clinical doctors. Prefer to local and spiritual treatment. If she come to uh, I mean tell to any family member that I have some problem in my breast, there are some lump or there are some pain, then she preferred to local treatment and spiritual treatment. She come to has Rohani Ilaj. Rohani Ilaj means she come to a religious follower and then ask, and he goes some uh, other activities that are not related to medical treatment. He gives some paperwork to band on the breast and some like that. And local treatment mean simple like homeopathic and other factors. And then low economic status. Of course, in the rural areas of South Asian countries, there is a big problem that people have very low economic profile and they cannot afford the expensive in a big hospital in a big cities. So these 5 are the main constraint from patient level factors that lead to delay in early diagnosis, and of course delay in early diagnosis lead to rise in a burden of breast cancer. and at the end, when they diagnosed, it's too much late and cancer has reached to higher grades. System level constraint. What are the factors from system and that lead to increase in cancer burden? Annually, we can say 175,000 people diagnosed with cancer and imposed further extensive social and economic strain on the already struggling health system of country. Country has a very low health budget. Total health expenditure is only 2.6% of gross domestic product, and facilities for cancer diagnosis and management are very limited in hospitals. Third one is there is still a lot of restriction in terms of both trained manpower and infrastructure. National policy about health lack the effective training programs, and patient to physician ratio is very high. Furthermore, country also lack no comprehensive register database to document the breast cancer death rates, accurate annually new case regarding the early management. And the limitation of research institute related to related resources is the main stumbling block for Pakistani researcher to evaluate the errors in gene function and further exploration about the breast cancer prevalence in Pakistan. So we can say the oncology treatment is not developed yet in Pakistan, although in the big city of Pakistan, they have well facility for, but it's not countrywide, it's not national level to each city. So there is a mass number of patients that lack and cannot get the main facility to treatment the breast. Clinical factors. Of course, as I mentioned before, there are three leading factors as system level, patient level, and clinical factors. As the general factor, we can say the BRCA1 and 2 positivity mutation contribute to early onset of breast cancer, and that is lead to many other like early menarche and hormonal imbalance and menopause in the higher age women. So BRCA1 and BRCA2 mutation contribute early onset of breast cancer. And there are two main big studies in the big city from like Karachi that severe vitamin D deficiency has been observed.
Hello. I think some technical problem. I think some technical issue with the presentation. Organizers, please. I think Dr. Nazir got disconnected. He's here. Please unmute yourself, Dr. Nazir.
Hello.
Yeah, no audible.
I'm really sorry. As you know, I'm living in China, and so there is a proxy problem. Hello, can you hear me?
Now you're audible. Please share your screen.
Sure. Here it is. It's fine now? Hello? Hello?
Hello.
Can you, is everything okay? Can I start now? Oh, thank you. Thank you. Just a minute. So here we was on the clinical factors. I was talking about the high usage of cosmetics. There is totally no check and balance for cosmetic, and the people mostly use to local and local and cheap brand for their skin compulsion and skin whiteness. So I, starting from my family history that we have lost in summer 19. So most of the women used un how to say, cheap and unregistered local hair dyes brand, and you know that those dyes contain para paraphenyldiamine in rural and semi-urban population, which contain high paraben content involved in mediating the breast cancer, thus contributing the breast cancer incidence. Next factor is the various risk factor, including the age, body mass index, marital status, priority, oral contraception, breastfeeding, smoking, physical activity, and menopausal status are the significantly associated with the increased risk of developing breast cancer in Pakistani women. Finding also revealed that the connection of genetic relatedness with the risk of breast cancer in Pakistani women. There are different studies who show the link between the cousin marriage and family linkage between in the breast cancer onset. So what we can do? What is the need of our? In order to address the urgency of breast cancer, Pakistan is in their need to initiate multi-pronged strategy, including better reporting, documentation of cases, community level awareness, promoting early detection for breast cancer, and overcome the barrier in the provision of better health facilities and making the diagnosis easy. So here we have recommendation, awareness and health literacy, affordable and accessible care, scientific aptitude to cope the disease. So here we discuss one by one. Pakistan need broader level, different multimedia, different media-based campaign to urge the women for regular breast self-examination and mammographic screening with regular interval of time. There is an urgent need to start culturally sensitive educative program about the women's health, especially breast cancer and its risk factor related to environment and lifestyle factor at the community level with primary care. Health Ministry need to launch massive awareness campaign on both electronic and print media to break all socio-cultural stigma and urge the women to walk in nearby clinics for breast examination. Educational material must be customized to promote the early breast examination women in case of any sign and symptom at school and college levels. It all demand the adaptation of multiple integrated measurement to set the trend of early presentation and breast self-examination in Pakistani women. What are the affordable and accessible cares? When we come to the system level, there is, as like patient, in the system, there is still too much need and there is too much things to get better. Expand health budget is the primary need, because going with increased health budget, we can construct well-equipped healthcare system at national level in all the cities of Pakistan and especially at rural areas, and specialize the trained staff. There is a lack of manpower, especially oncologists and the staff who deal with the cancer diagnostic instruments and other clinical offered affordable and easy to access treatments. Pakistan also in need to give the facility at rural area and semi-urban areas to affordable and easy accessible treatment to all patients. And it also need a long-term management policy with the data registry. Pakistan still, it's 2021 and we lack the national level data registration, national database agency that documents all the cancer patient, especially breast cancer, and then we can make a management program, long-term policy to manage this burden. And what is the scientific aptitude to COVID? Of course, when we have high funding, high infrastructure, we are in need to establish specialized research center. Although there are many research centers in Pakistan, but it's still lagged. As per data of breast cancer, we still need to establish specialized research centers, training of oncologists. We need a support from developed countries to train our doctors as specialist oncologists and nursing staff and other technical staff for the better curement of breast cancer. More fun to explore more about BC. Key to care cancer is early detection. As I speak early, unfortunately, coupled with delayed referral appropriate facility and late diagnosis in the country, mortality rate of breast cancer is high. Key to care cancer early diagnosis conclude in different studies. If we diagnose at early stages, there are greater chances of recovery and survival. And diagnosis at later stages, low chances of survival. Thus, it emphasized to spread awareness about the early diagnosis and treatment of breast cancer among the general public. Here I gave a motivation for those who are fighting with BC. One of Pakistani leading actress, Nadia Jamil, she recently diagnosed with breast cancer, but it was stage 1. And then she went through the treatment as surgery and chemotherapy. And then she won the war and she officially declared by his doctor team that she has won the war against cancer. So in conclusion, due to low health budget of the country, there are a scarcity of modern cancer care infrastructure. Pakistani women are deficient in knowledge about the breast cancer and follow many prevalent superstition and spiritual statement about the disease. Study highlight there is an urgent need to educate the women, promote early diagnosis of breast cancer, and ensure the better equipped public facility for palliative care of patients suffering from breast cancer. We believe with the further inquiries addressing the delay factor in early diagnosis of breast cancer in Pakistan, awareness and affordable, accessible healthcare system will win the war against breast cancer in women and improve the cancer survival rate in the country. In conclusion, I would like to present this overall conclusion pictures. Pakistan is urgent need to address the two patient level and system level for constraint, and recommendations is also about these two factors, like increase health literacy rate, educate the women, more awareness through social media, current media and print media to promote this breast self-examination, and system level. Of course, we need country need to expand health budget for advanced care setups all around the country, expand and introduce innovative policy and training program for breast cancer uh, as for oncologists, and develop national level cancer registry for to document the data and the prevalence rate in the country. Thank you so much for your attention. I would like to say I'm really pleased to join this biologist all over the world. Thank you again. Any question, please?
Dr. Nazir, thank you for your presentation. We all agree that good health is key to nation's development. And I think awareness, early detection, and adequate treatment are the tools against cancer. So
Exactly.
the best for your future endeavors. Thank you. Now, there's a small change in program. I invite Dr. Farid, Professor Farid from Iran for his presentation. Welcome, Dr. Farid.
Hello.
Yeah, Dr. Farid, welcome. Yeah.
Do you
Please
have
share
my
your screen.
voice? Yeah.
There's an option of sharing screen on the on the bottom of the screen, green color.
I see it, the desktop. No, I don't
Yes,
know
it's
if it's
visible now.
visible. Good.
Yes, your presentation is there. Thank you.
First of all, I would like to thank the organizers of this very nice program, and I'm really very thankful for having the opportunity to present in this webinar. What I'm going to talk about is about the diagnosis of idiopathic granulomatosis mastitis. As a matter of fact, I want to say that it is a clinical radiopathologic entity. And for diagnosis, there must be a kind of collaboration between the clinician, the surgeon, the radiologist, the pathologist, for reaching the correct diagnosis and managing the patient correctly. I want, first of all, let me introduce myself. I am Farid Azmide Erdalan. I am a pathologist in Tehran University of Medical Sciences, and here in above of this image, you can see the hospital where I work in. This is a very old hospital located in the beautiful city of Tehran, and I'm right now here, and I hope you will enjoy my presentation. Here you can see a very old hospital that it is built by a German company before the Second World War, and during the World War, this hospital, exactly what you can see over here, was occupied by Allied forces, and after the Second World War, this hospital starts its work as a hospital. As I told you, this is the main building of the hospital. The pathology department was used to located in this building, but now it has moved into the Cancer Institute. Of course, part of the pathology department was here, but the main section of pathology in our hospital is located in Cancer Institute. And as I told you, here's the main building of the School of Medicine of Tehran University of Medical Sciences. It's the school where I studied and where I'm working at the present time. And here is the hospital where I'm working, which is called the Imam Khomeini Hospital. And here's the Cancer Institute, the pathology department. The main pathology department of the hospital complex is located in this part of the hospital, which is called Cancer Institute. And the main building, the infectious disease building, and this Cancer Institute were all built in about 1930s, and the story that I told you. Here we have an educational hospital. We have so many happy and intelligent residents, and here you can see me and the other residents who are here. The majority of our residents are female. I don't know if the same has happened to other parts of the world, but in our country, female physicians are more interested in pathology than males. And here you can see me and my residents and colleagues over here. And as you can see, we are celebrating the New Year, the Iranian New Year, and all of the residents are very happy for this celebration. And here is another image which shows me and my colleagues. And here's the multi-head microscope where I do my daily work from early in the morning until late in the afternoon, and working with so intelligent and enthusiastic colleagues really makes me very happy and provides me a very good situation. I'm very happy to be here and to work with my students, and some of them are international students. Here, I want to show you an image. It's, of course, an old image before the chrono pandemic. And as you can see here, we have a multidisciplinary team for breast cancer. And this breast multidisciplinary team is composed of surgeons. You can see a couple of them here, radiologists, oncologists, and here you can see me and my colleague, they are pathologists. Our residents are also over here. And we discussed the cases in this multidisciplinary teams. And it is not just tumor board, it is just a breast multidisciplinary team. And any case is discussed here, including non-tumoral cases such as idiopathic granulomatous mastitis, but I'm going to tell you right now. And I really should say that most of the things that I learn as a pathologist is related to these sessions. Here we sit together, we think together, we discuss the cases, and I should really say that such sessions cannot be replaced by anything else, and they are much more important than many pages of a textbook. I would like to start my lecture with presenting some cases in order to make you familiar with the presentation of patients with granulomatous mastitis. Yesterday, I was very happy to see that a patient with idiopathic granulomatous mastitis was giving us her experiences and her journey through the disease, and it was very informative for me. As a matter of fact, I really make the diagnosis, and I see the slides of these patients, but yesterday I really had the opportunity to see one of those patients and understand what difficulties they encounter in their diseases. Okay, the first case is a 31-year-old woman with right breast mass, erythema and fistulizing lesion. There was some kind of fistula formation within the past 3 months. He has also a story of benign fibroepithelial lesion, probably fibroadenoma in the left breast 6 years ago, which was biopsied and was completely benign. But now on the other breast, she has a lump, a hypoechoic mass on diagnostic images, a hypoechoic mass with irregular margin at 3 to 12 o'clock of the right breast in favor of idiopathic granulomatous mastitis is identified. As you can see, even the radiologist most of the times can suggest the possibility of an inflammatory process or idiopathic granulomatous mastitis, particularly our experienced radiologists are really able to suggest the possibility of idiopathic granulomatous mastitis. And when it is written in the request for histopathologic evaluation, I know that if I find features in favor of idiopathic grammatous mastitis, my findings are concordant with imagings. Therefore, with this impression, corneal biopsy was performed, and as you can see, some pieces are submitted to the pathology department. Here, you can see an image of the whole slide, as you can see at this very, very low power. You can see all the cores that I had for evaluation. And as you can see from this low power, there are some bluish areas. Which are interspersed, are distributed almost regularly between some pink areas. The pink areas are the areas of the breast that have no significant inflammation, and the bluish areas are the areas of the breast which with much more inflammation. It is exactly what we really want to see, and what we usually see in idiopathic grammatous mastitis. We see portions of the breast that have inflammation and portions without inflammation or with less inflammation, and these inflammatory areas are mostly centered in lobules, in terminal duct lobular units, as you can see in this higher magnification view. And here you can see the interlobular areas which are devoid of inflammatory cells. So as you can see here, the inflammation, the bluish areas are centered in lobules or terminal duct lobular units. And if we have a closer look, as you can see here, we see some histiocytes, epithelioid histiocytes that really have not formed, produced well-formed granulomas. They are just vaguely identified granulomas. Granulomas are not very well-formed in this case, but as you can see, it's not the only inflammation. We have some inflammatory cells, including some lymphocytes. And again, you can over here understand the lobulocentric nature of the inflammation. Most of the inflammation, the bluish areas, are centered in the terminal duct lobular units with interlobular areas with much less inflammation. Again, puliform granulomas and the mixed inflammatory infiltrates, which can see over here. Here you can see the pathology report. Just I want you to pay attention to diagnosis. What I have written in the, diagnosis line is lobulocentric and confluent grammatous reaction, mixed inflammation, and microabscess formation. No evidence of calcification, ATP, or malignancy. And as you can see here, I've added a comment that further evaluation for potential etiologies of grammatous inflammation, particularly infectious agents, is recommended. As you can see in the microscopic description, I've performed Ziehl-Neelsen, PS, GMS stains for acid-fast bacilli and fungal elements, but they were all negative. And at the same time, I had this kind of lobulocentric inflammation. But despite these stainings, I have also suggested further clinical laboratory investigation for infections, infectious agents, and other causes of grammatous inflammation, such as sarcoidosis or vasculitis, some types of vasculitis. And then I've written here that if other etiologies of grammatous inflammation are excluded by further clinical laboratory investigations, idiopathic grammatous mastitis may be considered in the appropriate clinical radiologic context. And as you can see, I have emphasized the importance of correlation with clinical and radiologic findings and exclusion of other causes. It's you know, the type of practice that I usually do, and I would really like to know comments from other pathologists and also colleagues from other disciplines about this kind of approach. Let me go to the second case. The second case is a 27-year-old woman with pain and swelling in lower inner quadrant of the left breast for 2 months. US study shows a hypoheteroechoic mass with lobulated border measuring about 3 centimeter at 7 to 9 o'clock of the left breast, and the Barrett's category is 4A, and the clinical and radiologic impression was also grammatous mastitis. And as you can see, corneal biopsy is performed, and I have something around 6 centimeter of breast tissue. And again, as you can see, this is the whole slide and all the pieces that I had, the fragments of breast tissue. Here, as you can see, the inflammation, the bluish areas are more confluent and probably saying that it is labulocentric is a little bit difficult, and we cannot be sure of labulocentric nature of this inflammation very easily based on what you can see in these images. And here, as you can see, if you pay attention, in some areas, the bluish color is accentuated, showing more inflammation. Probably these areas are the lobules. And in some areas which are less affected, the fragments that are less affected, probably the labulocentric nature of the inflammation can be understood. And here you can see, you know, this higher magnification, as I told you, in this case, the inflammation is more confluent, and so depicting the labulocentric nature of the inflammation seems to be a little bit harder than the previous case. Here you can see the inflammation, the inflammatory infiltrate, which is composed of mixed inflammatory cells. I will show you in a bit higher magnification. Here you can see that inflammation is mixed. And we have neutrophils, polymorphonuclear leukocytes, and in some areas, microabscess formation is evident, along with some lymphocytes, histiocytes, and again, a pulley-formed probably granuloma. But in the center of the granuloma, we have a vacuole, as you can see here. We have an empty area in the center of this granuloma. And at the periphery of this vacuole, as you can see, we have some neutrophils, but the neutrophils are sparse here in this image, but you can find some neutrophils here around this clear area. And then we have some histiocytes. With higher view and higher magnification, and probably with gram staining, sometimes we are able to find some gram-positive bacilli in these cavities. But I was not able to find any microorganisms in this case. And here, as you can see, I have rendered this diagnosis. In the diagnosis line, I have written labulocentric and confluent. Probably I should say confluent and labulo. Sorry, I should say confluent and labulocentric, because the confluent pattern was more prominent than the labulocentric, with mixed inflammation, microabscess formation, and microcystic changes in the center of granulomas. And again, no evidence of calcification ATPR malignancy. And as you can see, again, I've suggested further evaluation for potential etiologies of granulomatous inflammation, particularly infectious agents. And as you can see, the second comment is that if other etiologies of granulomatous inflammation are excluded by further clinical laboratory investigation, cystic neutrophilic granulomatous mastitis, or CNGM, is suggested in the appropriate clinical radiology context. I've added that cystic neutrophilic granulomatous mastitis is considered as a variant of idiopathic granulomatous mastitis by some authorities. But others probably consider it as a distinct entity, but really I think that probably we can consider cystic neutrophilic granulomatous mastitis, a variant of idiopathic granulomatous mastitis, with a kind of infectious agent which is identified in this case, and our clinicians know that in these cases they can try antibiotic therapy besides other medications that are given for idiopathic granulomatous mastitis. Okay, let's me go to the third case, a 38-year-old woman with mastitis. And on a US study, heteroechoic mass with edematous margin measuring about 4 centimeter in diameter is identified in the left breast, virus category 4A. And again, I have some core needle biopsies, and as you can see, about 6 centimeter of breast tissue. Again, as you can see, we have some cores of breast tissue. Looking at the cores at a very low magnification is very essential. And sometimes I do what you can see here. I scan my slides and then I try to look at them at a very, very low power. And in this case, I can be able to discern the labulocentric nature of the inflammation. As you can see, the inflammation is accentuated. The bluish areas are accentuated in some areas and less in other areas. In some fragments like this one and this one, the inflammation is more confluent, but here the inflammation is patchy, and higher magnification confirms the labulocentric nature of this inflammation. Again, you can see the inflammation, which is accentuated in some areas with, as you can see, labulocentric accentuation and paucity of inflammation in the interlabular areas. Here you can see that the granuloma in this case is much more well formed. Here you can see a granuloma which is relatively well formed. I really want to show you with these 4 cases the variation on the theme. You can see that in some cases inflammation can be much more extensive. In some cases inflammation can be less extensive. In some cases we have poorly formed granulomas. In some cases we have well-formed granulomas. In some cases we have microcystic changes surrounded by neutrophils and things like this. Here you can see the granuloma, the inflammation, the mixed inflammation, as you can see here, a well-formed granuloma with higher view. And here you can see that we have remnants of the terminal labular unit, confirming the labular centric nature of the inflammation and the granulomatous reaction. And as you can see here, the inflammation, the higher view of the well-formed granuloma, you see aggregates of epithelioid histiocytes surrounded by some here predominantly lymphocyte, but in some areas, neutrophils and even microabscesses are seen. Here again, very extensive inflammation. As you can see, the failed-form granuloma, even you may find some giant cells. Mostly the giant cells are of foreign body type, and the inflammation here is very extensive. Here you can see the giant cell, the Langhans type giant cell, well-formed granuloma, and the infiltration of predominantly lymphocytes around this granuloma, and in some areas you can see more neutrophilic infiltration, as you can see here, more neutrophilic infiltration, even microabscess formation. Again, in this case, we have some microcystic areas, but the neutrophilic infiltration around the microcysts are much less. But I think in this case, I could find some bacillary structures within the cyst. As you can see, it is surrounded by the granuloma, the epithelioid cells, and in the outer part, we have predominantly lymphocytes. Again, you can see the inflammation, which is lobulocentric in this case. In interlobular areas, inflammation is much less. Again, the diagnosis was lobulocentric and confluent grammatous inflammation, just like the previous one. And I mentioned that other etiologies of grammatous inflammation, particularly infections, should be excluded. I really would like to emphasize infection because I think infections are the major differential diagnosis. If infections are not excluded, giving these patients corticosteroids or some kind of immuno suppression that is sometimes applied may be very dangerous for these patients. Therefore, infections should be excluded by clinical laboratory studies. And commonly, separate specimens are submitted at the time of surgery when there is strong suspicion for granulomatous mastitis, at the time of biopsy, and when the biopsy has proven this diagnosis at the time of the surgery that is sometimes done for, somehow, debulking the mass or draining the pus and purulent materials. And at the same time, they take some samples and send it for mycological studies, bacteriological studies, and PCR for Mycobacterium tuberculosis and other things. And at the same time, further laboratory evaluations for other etiologies of grammatous inflammation, including vasculitis and probably sarcoidosis, will be done. And then, as you can see, I have also suggested the possibility of cystic neutrophilic grammatous mastitis in this case because of those microcystic structures that you saw. And as I have also added that it's a variant of idiopathic grammatous mastitis. And the last case is a 45-year-old woman with breast mass. This patient also has presented with breast mass. Mammography shows a well-defined density at central zone of right breast, and US study shows several iso and hypoechoic well-defined areas with internal echo, about 18 millimeter in probably its left is not correct, it's the right breast because the specimen is taken from the right breast. And here you can see we have something about 8 centimeter of breast tissue. The findings are almost the same as the previous cases. You can see the lobulocentric nature of the inflammation, the accentuation of the inflammation within the lobules. And here you can see that granulomas are well-formed, giant cells are very numerous. In this case, We have a great deal of giant cells. In previous cases, we didn't have so much giant cells, and here you can see the inflammation within the lobule, mostly lymphocytes, but in some areas it's producing some kind of granulomas. And again, you can see neutrophilic infiltration and probably microabscess formation. And this is another area, the lobulocentric, and the accentuation of inflammation within lobules, and the opacity of the inflammation in interlobular areas. As you can see here, the interlobular areas are not devoid of inflammation in this case, but the inflammation is much less. Again, I made a diagnosis almost similar to the previous cases, and idiopathic granulomastocytosis was suggested in the appropriate clinical laboratory context. Here I would like, after evaluating these cases, as you could find from all of the cases, is that most often patients with idiopathic granulomatous mastitis present with lumps, with masses in their breasts. It's very common, but at the same time, they may be edema, erythema, fistulization, and things like that. It is more common in porous women, and the triad for a typical case of IgM, idiopathic granulomatous mastitis, is what I've shown here. You must have all of these components to call it a typical case of IgM. The inflammation should be lobulocentric. You must find granulomas. Never you can make a diagnosis of idiopathic granulomatous mastitis when you don't have any granuloma. The lobulocentric nature of the lesion sometimes are very, difficult to discern, but we must search for areas to show the lobulocentric nature of the inflammation. And another essential component is neutrophils. Without neutrophilic infiltration, we cannot call it a typical case of IgM. All these components should be present in a case to be called a typical case of granulomatous mastitis. As I told you, chronic neutrophilic granulomatous mastitis is a variant of idiopathic granulomatous mastitis, but some authorities consider it as a separate entity. But you must know that in these cases, we are able to find a microorganism, a Corynebacterium, and this is what really differentiates it from other types of idiopathic granulomatous mastitis. And the histology is, as you could see in 2 of the 4 cases, we had some cysts. In the center of the cyst, we had, sometimes we have some bacillary microorganisms, positive bacilli, which are the Corynebacterium, surrounded by a rim of neutrophils. And as you can see, the variation along the theme, the thickness of this neutrophilic cuff can vary significantly. In one of our cases, you could just find few neutrophils, but in other cases, we have a very big rim of neutrophils, and then we have epithelioid cells and lymphocytes in the outer portion. Now I would like to tell you about atypical forms of IgM. Sometimes the IgM is not so typical, and in these cases, you must really think of alternative diagnosis. Let's review some atypical forms of granulomatous mastitis. These are all atypical, and when you see, these features, you must think of alternative diagnosis. When there is presence of acid-fast bacilli or fungal elements or microbial colonies, probably you are dealing with an infection. Probably it's tuberculosis or fungal infection, or even an abscess. Then the diagnosis of IgM is precluded, and you must treat the patient relevantly. When there are foreign bodies, and the giant cells granulomas are foreign body type, and you identify the foreign bodies in the breast, and the diagnosis is foreign body granulomatous reaction and not idiopathic granulomatous mastitis. When we have epithelioid granulomas with casus necrosis, it's very typical for tuberculosis and some other infections. In these cases, we must think of infections and not IgM. When we have marked eosinophilic infiltration, you must think of parasitic infestations when there are marked eosinophilic infiltration, or sometimes some types of vasculitis, Church-Strauss. We have a kind of angiitis with marked eosinophilic infiltration. We have also seen cases of granulomatous inflammation in the presence of some atypical cells or even invasive breast carcinomas. So be aware of presence of atypical cells or evidence of malignancy should be carefully searched for when we encounter an inflammatory process or granuloma. We have also reported 2 cases with invasive carcinoma, 2 cases of invasive carcinoma, which were previously diagnosed as IgM erroneously. Another point that should keep in your mind is that extensive necrosis with or without vasculitis is not a feature of IgM. You should think of vasculitis in these cases. When the inflammation is not lobulocentric, you must also consider other etiologies, but be aware of the fact that because of confluence of the inflammation, the lobulocentric nature of the inflammation becomes difficult in some cases to be identified. If you have just granulation tissue with microabscess formation, you are dealing probably with an abscess wall and not a granulomatous mastitis. When you have naked granulomas, probably you are dealing with a case of sarcoidosis, and it's very atypical for IgM. When you have ectatic ducts with xanthogrammatous inflammation around ectatic ducts, you must think of duct ectasia, mammary duct ectasia, and not idiopathic granulomatous mastitis. When you have lymphocytic infiltration in lobules accompanied with keloidal stromal fibrosis and epithelioid myofibroblasts, it's a very rare entity, but I've had some of these cases. There are diabetic mastopathy or lymphocytic mastitis, and you should also consider it in differential diagnosis. In these cases, we don't have granulomas. And these features are very atypical, and when you have these atypical findings, you should mention it in your report. I think the main part of my lecture is this flowchart, and I think if you follow this flowchart, probably you can help your patient and you can arrive at the correct diagnosis. A corneal biopsy with or without clinical radiologic impression of IgM. Is the histopathologic findings typical for IgM based on what I told you, the triad of granuloma, lobulocentric nature of inflammation, and neutrophilic infiltration? And is the findings concordant with radiologic and clinical findings? Exactly what I had in the 4 cases that I showed you. In these cases, I say IgM is the diagnosis. If other etiologies of grammatous inflammation, particularly infections, are excluded by further clinical laboratory investigations. But if we have typical features of IgM, but the clinical radiologic findings are not concordant, it's discordant. Maybe you have an invasive carcinoma with features similar to IgM in surrounding breast, then rebiopsy is strongly advocated. When the histopathologic findings are atypical for IgM, as I showed in the previous slide, but the possibility in these cases, sometimes the possibility of IgM is excluded, as you can see here in this third arm of this flow chart. When, for instance, we have acid-fast bacilli, we have fungal elements, and we have foreign bodies. When in the third arm you have histopathologic findings suggestive of or characteristic of alternative diagnosis, then the diagnosis and the management would be based on the alternative, diagnosis. But if the histopathologic findings are atypical but not characteristic of a specific etiology, then further evaluation and resampling is advocated. And the thing that I really want you to keep in your mind is that IgM is not a pathologic diagnosis. Never I make a diagnosis of IgM in the diagnosis line, as you could see in the sample reports that I showed you. I just described the findings. I say it's lobulocentric. I have mixed inflammation. I have microabscess formation. I have granulomas. I have microcystic changes, and so forth. And then in the comment, I say it could be IgM in the appropriate clinical radiologic context and after exclusion of other etiologies. So diagnosis of IgM is clinical, pathologic, and radiologic. Here I would like to show you the picture of the father of pathology in Iran, Dr. Mustafa Habibi, was the father of modern pathology in Iran. And as you can see, he lived just for 44 years and died very soon because of heart attack. And I found this article, which is in Farsi. It is about the diagnosis of breast tumors, which is related to this Congress. So I wanted to show it. It's about the diagnosis of breast tumor using trans-illumination of breast tissue. It's an article that is written by this gentleman who is considered the father of pathology, modern pathology in Iran. And I really want to acknowledge his efforts. Now I come to the end of my story. Here you can see my Twitter handle. I would be very happy if you follow me. I would be very happy if I can receive your comments. I put some of my educational cases in my Twitter, and you can also find me in LinkedIn. And here I would like to finish with an Iranian poem which says به پایان آمد این دفتر حکایت همچنان باقی است به صد دفتر نشاید گفت وصف الحال عشاقی. I've translated in this way that this book is finished, but not the story behind it. We cannot express our love and enthusiasm in more than 100 books. Thank you very much for your attention. I would be very happy to have your comments. And I'm
Thank you very much.
served.
Thank you very much, Dr. Fareed, for a very comprehensive, very informative, about the topic. We rarely get such cases in our setup. And I welcome any questions from the delegates. Thank you, Dr. Fareed. I think we are all very clear about the topic now and how to go about it. Thanks a lot. It was a privilege listening to you. Thank you.
Thank you very much.
Thank you. Now I hand over the chairperson responsibility to Dr. Ishani. She'll take over from now. Over to Dr. Ishani. Dr. Ishani.
Good evening, everyone. I thank UCG Conferences for giving me the opportunity to sit beside and talk to such eminent pathologists from all over the globe. I am Dr. Ishani Gupta, presently working as a senior resident in the Department of Pathology, GMC Jammu, Jammu and Kashmir, India. And all the sessions that have been taking place since yesterday are very informative, and it has widened the horizon of our knowledge of breast pathology and breast radiography and the new developments that are taking place in relation to the breast pathology. Now I would like to introduce our next speaker, which is Dr. Maxim from Russia. Over to you, sir.
Yes, here I am. How can you hear me?
Yeah, I can hear you.
Can you see me?
No, please
start
your
really
video.
upset fact because I turned on my camera and nothing happened. It's...
Sir, on your screen, if you can see.
So, and now?
Yeah, I can see there is, you have switched on your video, but there it's a black screen, blank it is.
Yeah, I can see it too, but in fact, I think I've just broken a camera or something.
You can share your presentation, sir?
Yes, of course, I can do it. And see?
Yes,
can
sir.
I see my presentation?
Yes, we can.
Okay, well, let's begin.
Yeah.
Greetings, everyone. My name is Dr. Maxim Nekhovich. I'm from Russia. I'm from Research Institute of Human Morphology of Russia. And today I'm going to talk about Paget disease of the breast and, of course, differential diagnosis in context of Paget disease of the breast. So, Paget disease of the breast, what is this? Is it an extremely rare type of breast carcinoma? Paget breast disease affected affects the skin of the nipple and usually the areola. Furthermore, the majority of patients with Paget breast disease also have one or even more tumors nearby the Paget carcinoma focus. These tumors are most often ductal carcinoma in situ or even invasive carcinoma. There is extramammary Paget carcinoma too, and we should keep in mind it. So, Paget disease is much more common in women due to the prevalence of breast carcinoma in women. And this presented only 1 to 4% of all patients with breast carcinoma. And most often the disease occurs in postmenopausal women, but also occurs in even adolescents or older patients. It should be kept in mind that Paget disease of the breast as well can occur in men. So, there are two main theories of histogenesis of this condition. So it's epidermotropic theory and malignant transformation theory. Epidermotropic theory. It is now widely believed that Paget breast disease is always or almost always associated with underlying breast carcinoma. Through histopathological examination, Robert Muir described the intraepidermal migration of malignant ductal epithelial cells through the mammary ducts and calls this process epidermotropism. It is generally accepted that Hergulin molecules are the cause for this hemataxis, and mainly heroglin alpha, which express normal cells of the epidermis and which interact with heterodimers of the hair group receptors. Binding of heroglin alpha to the receptor complex on Paget cells leads to hemataxis of these cells, which migrate to the overlying layers of the nipple epidermis. In addition, it should be noted that due to the above-mentioned mechanism, heroglin are able to control tumor metastasis. So it was proved that blockade of heroglin alpha expression sharply reduced the oncogenic potential of breast carcinoma, including Paget breast carcinoma. So that's how it works, and we can see here formation of pseudopodia and heroglin alpha associated hemataxis in Paget cells. And here we can see HER2 expression in Paget cells left and in atypical ductal hyperplasia right. And nearby this the both focuses, we can find even perineural invasion of ductal invasive carcinoma. And this is GCDFP15 expression of another case. So, malignant transformation theory. It is speculated that Paget cells may be derived from glandular stem cells or even Toker epidermal cells. Toker cells have been found in about 10% of normal nipples. Kwan in 2001 reported the immunohistochemical expression of apomorphins such as MUC1, MUC1, and even MUC5AC in Paget cells and concluded that both Paget cells and the underlying ductal carcinoma expresses the same phenotypic apomorphins that are also expressed by Toker cells, and they concluded about the interconnection of the above structures. However, Luca Morandi 2 years later, in 2003, reported that chromosomal changes observed in Paget cells are different from those observed cells of underlying breast carcinoma. This suggested that Paget cells are genetically different from underlying breast carcinoma cells. So, aim of our study to analyze samples of intravital pathomorphological diagnostics of patients with Paget breast disease, compare the obtained data with the results of other publications in the context of the above-mentioned topics, to develop practical recommendations for differential intravital pathomorphological diagnosis of Paget breast disease. So, material we used. We examined samples from 10 women with memory Paget breast disease from 2009 to 2020, respectively. The average age of the patient was 55 years. The method of light microscopy, as well as immunohistochemical technique, were applied. And of course, we use transmission electron microscopy. So it is really interesting case of gross examination of Paget disease, and we can see here just nipple. Yes, it's nipple and it's a little ulcerated, but nothing really especially. So if we look at this under microscope, we can find large cells, large pleomorphic cells, and even one of these cells have nucleoli, and it's really curious and really interesting. And it's the same case. And what we should note that mere histochemistry can be used. So you can set PES stain, and you can find granular cytoplasmatic inclusions in Paget cells, of course. So what about immunohistochemistry in Paget breast disease? So CAM52, GATA3, and HER2/neu, it's almost all what you need to do with diagnosis of Paget disease, because these markers almost often expressed by these cells. And of course, LMWLCK and another cytokeratins and another markers have variable expression by the cells. So it is CAM52 in Paget cells, and we can see here broad and strong expression of this marker. And of course, we can see broad and strong expression of GATA3 and CD138 Yekatgerin. And you should keep in mind that even mucins can be expressed by these cells, but expression of mucins are less than another markers. So differential diagnosis of Paget-like condition is Toker cells, and of course atypical Toker cells, melanoma, Weissner's-Nevels, and even bone disease. So let's talk about Toker cells. Toker cells is a normal cells, and as a rule, Toker cells have no pleomorphism, no prominent nucleoli or vesicular chromatin. Toker cells have found nucleoli and are usually concentrated along the basal layer of the epidermis, but can also be found in the surface layers. There is no such correlation, lack of pathological mitosis as a rule. And so can we see just large cells, but without any mitosis. But if we look at this closer, we can see some mitosis and we can see even nucleoli. And another field of view, we can see large cells. It's really interesting. So we can't just pretty easy distinguish these cells from Paget cells, for example. So there is a really interesting question, how we should distinguish these two conditions. And Sanhui Park suggested method based on cytokeratin 7, HER2, and Ki67 expression of these cells. Because as a rule, Toker cells have a less expression of Ki67 than Paget cells. So for example, this is Ki67 in Paget breast disease, and it's Ki67 in Toker cells. And we can see that Toker cells have a less expression of this marker. Can we distinguish these cells only based on this marker? Of course not, but we should keep in mind that Paget breast disease almost always associated with underlying atypical duct hyperplasia or even ductal carcinoma and ductal carcinoma in situ, etc., etc. So I already showed you this pic. So melanoma. Melanoma have atypical melanocytes are often located predominantly as single cells. LTAT nets may also be present, of course. Individual melanocytes often form confluent proliferation along the basal layer and attract additional structures. Melanocytes vary greatly in size at amount of cytoplasmatic melanin, may be even absent, as well as a degree of nuclear atypia. Multinucleated giant cells and even starburst cells may be present. There are more mitosis and of course, including atypical mitosis. What about immunohistochemistry? Immunohistochemistry markers that we can use is HMB45, Milan A, S100, and S100, I'm sorry, and another markers of melanocytes. So here we can see gross image of melanoma of the nipple, and we can see two ulcerated nipple. So if we look at this under microscope, we can see large cells, mitosis, and of course atypical mitosis. And this is another field of view. So we set melan A, and we proved it was melanoma. So okay, can we diagnose this only based on melan A? Of course not, and S100 as well as melan A expressed by the cells. So there is another melanocytic proliferation disease, so as Weissner-Nevus. So what is Weissner-Nevus? Weissner-Nevus, also known as BAP1-OMA or just BAPOMA. What characteristic of Weissner-Nevus? Pagetoid differentiation with diffuse atypia. Atypical cells are found in all layers, in some cases dermal invasion is possible, and mucin stains, of course, are negative. There are more mitosis, including atypical mitosis, than Paget cells have. Of course, melanocytes markers can be used, and a characteristic and necessary criterion for the diagnosis is negative BAP1 expression. So it's how it can look. And BAP1 expression and even negative BAP1 expression is necessary criterion for this diagnosis. So bone disease. Bone disease have squamous cell differentiation, diffuse atypia. Atypical cells are found in all layers, but no dermal or myoepithelial progression. Pagetoid cells with abdomen pale cytoplasm and large pleomorphic nuclei are widespread in the epidermis. And of course, mucin stains are negative. There are multiple mitoses, and multiple mitoses are more than Paget carcinoma have. So epithelial membrane antigen expressed by these cells, as well as P63 or another squamous cell markers. So it is another case of bone disease of the nipple, and we can see here, in fact, the same. We can see large cells with mitosis, etc., etc. But if we set up P63, we can see that these cells have squamous cell differentiation, and it is not Paget breast disease, but it is Bowen's disease. So what about results? We developed practical guidelines for the differential diagnosis morphological approach to Paget carcinoma and Pagetoid lesions, which are used in Russia routinely. So it is our panel, and if you don't mind, I suggest you to use it also. So increase the probability of successful diagnosis of Paget breast disease, reduce the probability of inadequate diagnosis and overdiagnosis, and this recommendation allow to predict tumor progress more adequately and to prescribe treatment individually for each patient. Thank you for your attention.
Thank you so much, sir. Any questions?
Yes, hello.
Hello.
Dear Maxim, thank you for your presentation. And you have very interesting course today, but I have some question. Are there all 10 cases located in nipple, or maybe you have extra nipple disease?
Oh, no. Let me see. No. All 10 cases was Paget disease, and I have another cases of breast melanoma of the nipple and Bowen disease of the nipple, and another cases I showed here now. So, but the 10 cases was Paget disease, of course, yes.
Thank you.
You're welcome.
Any more questions from anybody?
Good morning. I just have one question about the melanoma. Do you use any molecular tests like BRAF?
No. We didn't use BRAF because this patient, in fact, had no money for this test, and that's all. She just denied from this test, and it's really sorry condition. And
Oh, got it. Thank you.
you're welcome. Another question?
More questions, please. I think that's it, Dr. Maxim. Thank you so much for such enlightening us with this. Now I would like to invite our next speaker, Miss Akriti Gupta from India. Hello, ma'am. Over to you.
Hello everyone. I am Akriti Gupta from India. I am a young researcher and I have been working in the field of cancer, particularly in terms of awareness, mental health, as well as how their quality of life is impacted. I have been researching in it. I have been working on field as part of my organizations, and recently I have done a very detailed study on how mental health and quality of life of breast cancer survivors is impacted, especially in the Indian context, all over India. So I would like to present my presentation on it. I hope my screen is visible to you all.
Yes, ma'am, it is visible.
Okay, thank you so much. Um, Again, like how we have worked upon this is we have taken a multi-stakeholder approach where instead of just interviewing, it's a qualitative study that we have done, and instead of just interviewing the patients, we have actually also interviewed the doctors, the caregivers, the nurses. Hence we have got a holistic know-how of what exact problems breast cancer patients face. And at the end of the this study, I would also like to discuss a case on importance of breast prosthesis. So coming to objectives and questions that we are going to cover in this presentation is to understand mental well-being and distress-related issues that breast cancer patients and survivors face post-mastectomy in India. And this will include that what exactly mental health issues they face, especially after undergoing mastectomy, what factors lead to these mental health issues, and how they impact their day-to-day quality of life. The second objective was to understand psychosocial experiences of breast cancer patients and survivors from the perspective of various stakeholders. So now what happens, the patients, the survivors, they talk to different stakeholders and they share their problems in different ways. Like for example, a patient, a survivor will share her problems with doctors in a different way, with nurses in a different way, with their caregivers in a different way, and with social workers in a different way. And again, so we try to understand these psychosocial experiences of breast cancer survivors, and as we talk to so many different stakeholders, therefore we were able to actually gather insights that they got after talking to thousands and thousands of breast cancer patients across their careers. And then as I mentioned, at the end I would like to discuss a case where it explains the role of external breast prosthesis and how what kind of role it plays in coping mechanism related to mental health issues post mastectomy, and what role it plays on quality of life of breast cancer patients and survivors. So coming to a little bit of literature that is already available out there, we understand that the social importance of breast in general in society is huge. It is a symbol of femininity, beauty, motherhood, and definitely a sense of attraction for most of the societies across the world. Also, breast cancer is the most common cancer in the world, and again a most frequent one. And burden of cancer is actually shifting from developing nations to from developed nations to developing nations like India now. Now in India, it is very interesting that though breast cancer is the highest occurring cancer in women in India, but also for example in the West, most of the cases, like 60 to 70% of the cases, are diagnosed in the early stage, but in India 60 to 70% of the cases are diagnosed in the later stage. And that happens because of low levels of awareness, because of taboo about the subject in general, and also about because of the low medical facilities available in India. So like if we compare in India, only 1,000 of 100,000 patients go for breast conservation treatment. The rest have to go for mastectomy in India. And primarily this happens because of two factors. Number one, because the cancer itself is diagnosed in a very later stage, that saving the breast is not an option now, or the at the center where the treatment is happening, the facilities are not such that conservation treatment can be done. So both the factors come here into consideration. So again, the existing literature says that after removal of breast cancer survivors face body image issues. Also, with mastectomy, as axillary lymph nodes are removed, therefore it restricts to certain extent physical participation of breast cancer survivors in certain valuable activities. And them Okay, so we have a question about how about screening with mammograms. So again, like coming to Indian scenario here, a simple practice of breast self-examination is also not known by most of the women. This study does not include that, but another study that we did, according to that, we took the sample of educated women who were pursuing their masters or even PhD. From the top social sciences institute in India, and out of that population as well, only 7% women were initially practicing breast self-examination. So going for mammogram is a challenge, and again there are two factors to it. Number one, India itself is a very patriarchal society. A lot of taboos are related to cancer as well as related to breast, so there is a sense of lack of awareness. Most women don't even know that mammogram sort of tests exist, and even if they know that there are mammograms out there, they just don't go out and get themselves tested because of two factors again. Number one, because the test is related to their breast, a scan in their breast has to be done, and again it's a huge taboo subject in India. And number two, these are pretty expensive. Like health insurances in India, again it accounts to only 10 to 12% people in India are covered under health insurance, and also there are not fixed mandates in these insurances that mammograms need to be done. Secondly, these insurances do not cover the costs of mammograms, which is pretty high. And number three, from government side, from public health side as well, there are not many public facilities available around India where you can get a free of cost mammogram done. So again, all these three factors culminate to the fact that we have a huge gap where early detection of cancer itself is a huge issue, because in fact we have had cases where women could feel lump inside their breast, but they did not go to the doctor until and unless it felt of the size of a tennis ball. So there's extreme lack of health seeking behavior that we can see in the population. And secondly, there is even if there is health seeking behavior, bigger question mark is that do we have enough facilities to accommodate the demand for it. So again, I hope I answered your question. So coming back to my presentation, so again, as I mentioned, that due to mastectomy and axillary lymph removal, physical participation of breast cancer survivors in various activities, like for example, in India, a lot of women are restricted to their household work, which involves a lot of rigorous activities, including washing clothes from their hands, cooking from their hands. And again, these activities are very rigorous. And after the axillary lymph nodes are removed, a lot of times and they suffer from problems like lymphedema, which restricts their activities, which further adds to their burden. And due to not being able to perform these tasks, there is a care receiver's guilt on the other hand. Women tend to feel guilty that already my family has spent so much on my health, and now I'm not able to give them now they have to take care of me again and again. Like my sons have to cook meal, my husband is suffering in his business because he has to take care of me. So there's a sense of care receiver's guilt as well. Then breast cancer survivors post mastectomy often avoid going out in the social spaces, and because they perceive to carry social embarrassment. And then role of external breast prosthesis is significant. Breast cancer survivors using it reported better perception of body image, and others said breast cancer survivors who wore EBP for others. So again, like but as you all can see in all these literatures, you see a very few Indian names. And in fact, while researching, we could hardly find any papers which were written in context of the Indian environment, and hardly any covered a multiple stakeholder approach. So therefore our methodology included a sort of mixed methodology, but more towards qualitative side, where we used primarily two tools. First was in-depth interviews, and second was survey, which was primarily used for the case that I would be discussing at the end. And the analysis of the data was done via Atlas TI and MS Excel. So coming to the sample and data collection, So this is about the first part of the study that I would be discussing. We conducted in-depth interview of 9 breast cancer survivors and 6 stakeholders in total. Out of these 9 breast cancer survivors, 5 were just breast cancer survivors and 4 were actually peer counselors as well. Like they were breast cancer survivors as well as peer counselors who used to counsel other breast cancer survivors. Therefore, the kind of insights they had, it was of more than thousands of breast cancer survivors they had talked over the years. Then coming to stakeholders, we talked to caregivers, nurse, doctors, that included both surgeons as well as psycho-oncologists. So the findings from this actually came around related to body image, where we found that the body image is one of the biggest factors that that is hit hard because of mastectomy, where severe body image issues happen because of not just loss of breast but also because of loss of hair, skin pigmentation, and blackening of nails. Often it is seen as a shift of perspective of own self and image. Women even quote that they see themselves as a different person altogether again because of the kind of changes they see in their body. They feel a sense of emptiness, and uh, the bigger issue is that not how I see myself but how others are looking at me. There's a sense of fear of loss in the sense of their identity, fear around how my body has disfigured. Certain insecurities are there, that I don't look nice, so how is my husband going to look at me? Or if the woman is younger, so is someone going to marry me at all? And then of course there's embarrassment and a sense of guilt as well. So again, I would like to mention few quotes that actually touched a heart, where women quoted that no hair, no breast, what is left in me as a woman? So this is a breast cancer survivor who is middle aged. She had 2 kids, and she mentioned this thing, that during her treatment she used to feel this way. Then looking at the mirror for the first time after surgery was the worst moment of my life. So again, the breast cancer survivor quoted this after her mastectomy, and again after her first chemo was done, and she had gained a little bit of weight in the hospital itself due to medications, and that's what she mentioned. And again, a psycho-oncologist said that she often uses the word like that women define themselves as ugly monsters, or they just don't want to see themselves in the mirror. So again, all these quotes signify that how severe body image issues these women face. Then coming to femininity, how women perceive themselves, and how they see that how this procedure has impacted their femininity. So number one is, of course, women relate breast with their womanhood, often quoting what is woman without her breasts. So their sexual life is often impacted hard. And again, a role of husband here is something that we explored, that if the husband is counseled properly, then probably these kind of impacts on body image as well as femininity can be lower than other women, if the husband is on board. Then younger women have greater impact on our femininity than older ones, as you can imagine that a woman who is in her 20s and is yet to get married, or is not in a relationship right now, or even if in a relationship right now, she sees a future, she sees herself in future, that what am I going to do, the way I look, am I going to find a life partner at all? Then scars from surgery, hair loss from chemo, and skin burns from radiation, of course, makes things worse. So again, some cases I would like to quote here is, after losing my breast as a 24-year-old, I felt no one is going to marry me ever. Then okay, so within skin, black breast removed, a big scar over my chest, and no hair, I hardly stepped out. So this woman actually said that she closed herself inside her house because she was scared to move out at all. And women are often afraid of having sex after the treatment. It is the husband too who needs to be counseled. So this is something that was shared by the nurse, who said that again, as most of the doctors in India are actually male, and sex again is a very much of a taboo subject for women. So they are not very comfortable in talking about their sexual life and how it is going to be impacted, what kind of problems they are facing with doctors, and instead they go to nurses to discuss that. And that's when a nurse told me that a lot of patients come to me after talking to the doctor, that okay, how am I going to have sex, or how it is going to impact our life in that way. And then she often, the nurse said that often it is not just the woman who needs to be counseled, but it is also the husband who needs to be counseled and told that how they can impact uh, their recovery, and how they can make her feel comfortable maybe, and also even making the husband feel comfortable with the big change that has happened in his life too. So coming to societal acceptance and exclusion, again this is a huge issue that we found in particularly in Indian context, where societal acceptance was a big question mark, where women sometimes face body shaming. Stigma of cancer survivor and association it with the family was a big issue here. Well, often where a lot of women said that they face difficulty, that their children uh, were getting married, and they felt there was certain extent of difficulty because the other family was not accepting the daughters or the sons because the mother had breast cancer. So there's a certain stigma related to cancer overall in India related to that, which makes the entire situation even worse. And of course, a lot of women quoted that they felt inferior in the social groups because of lack of breast and lack of hair. Many a times, anxiety triggered by social sympathy and unwanted inappropriate questions and tendency to avoid social interactions. So again, this is also a huge thing, where a lot of courts came that how women shut themselves inside their houses, or even relocated their houses at all, just so that people don't come and ask unwanted stupid questions like are you going to die, or when are you going to die, or are your hair going to come back again at all, or just receiving the unwanted sympathy, or people looking down to them that oh my god, what has happened to them. And that used to trigger a lot of anxiety. So again, all of this comes because there is a extreme lack of awareness in India around what is cancer. People, there's a basic knowledge about cancer as a disease is missing, and that is the very reason why myths around cancer have perpetuated so much in the society, which makes them even difficult for breast cancer survivors to step outside with dignity after their treatment is done. um, so coming to quality of life, so with breast removed, especially with women with bigger cup sizes, with bigger breast sizes, there's a lot of discomfort that they had while walking and while movement, and which was primarily happening because of the body imbalance they faced. Like because one side there was breast and the other side there was no breast, so there was a sense of weight balance inside the body, and because of that there was discomfort while walking, while movement, and also many face dropping of shoulder and bending of spine because of that. Then body asymmetry and social exclusion, of course, because the woman has breast on one side and not on the other side, there was a sense of body asymmetry, and because of that itself, a lot of body image issues were happening. And low body strength and confidence often impacted on livelihood. Okay, so this is a very important point. I would like to mention another case here, where a woman was a teacher before getting diagnosed with breast cancer. And what happened was that because number one, her breast was removed, she was so conscious that how is she going to face children with that kind of a body structure. And secondly, because she developed problem of lymphedema, though she was regularly going for her physiotherapy sessions, but she could not raise her hand or her so her right breast got removed, and because of those problems she was not able to work properly with her right hand. For example, she said, I was not able to check a lot of notebooks or write on board, for that matter, on blackboard or on whiteboard, for that matter. I could not raise my hand, therefore I had to quit my job. Similarly, the other person was a dentist, and she said that what is a dentist without her arm strength? I could not do simple procedures in a patient's mouth. And again, that impacted her livelihood, at different levels. So, and on, not just that, not just on professional level, but also women are often not able to do their day-to-day tasks. Like, for example, they're not, if they're going for grocery shopping, they are not able to pick up heavy bags while coming back, or they are not able to cook certain dishes that they used to for their family. So because because of these kind of changes that happen in their day-to-day life, again, it everything, you know, impacts to their psychosocial levels at different levels. So, you know, as cases can be seen here, I am not able to even cook properly now. My hand just does not permit me. Or having a dental clinic, my stamina is so much less now, definitely impacting my income. So now coming to coping mechanisms and particularly role of breast prosthesis, I see some questions in the chat box, and I think I will be taking them later on. Okay, so I'll take it after the presentation. So coming to role of breast prosthesis and other coping mechanisms, first thing was that women who were part of peer counseling groups, there was a huge difference that could be seen. There was a feeling of empathy in the peer counseling groups instead of sympathy, and being part of the same community made a lot of difference. They did not feel alone. They did not feel that I'm the only one who's going through this. And of course, significant strength was gained by peer counselors on doing this work as well. So coming to peer counselors, they mentioned that there's a lot of sense of emotional fulfillment in it, because again, as just breast cancer survivors, before getting into peer counseling, they often used to feel that this has happened to me, or why am I suffering this, why me, kind of questions were a lot happening. But when now they talk to hundreds of other women like them, they feel a sense of emotional fulfillment. There was a sense of positivity that could be noticed there. Then the third was psycho-oncologist as a professional support. It is a very big coping mechanism. Patients who were regularly going to psycho-oncologists, or even had few psycho-oncology sessions during their treatment, and versus patients who were not going to psycho-oncologists, the difference could be pretty evidently seen. Now, coming to caregivers, they are probably the biggest coping mechanism in the entire process, because they provide the maximum emotional support to the patient. They are the loving family members, they're the loving friends who have been with the patient throughout their lives, and they can provide emotional support during treatment as well as after the treatment, helping patients to get back into the society with dignity. Doctors, surgeons, again, coming to particularly in India, they were not able to devote a lot of time, because again, if you see, doctor is to patient ratio in India is itself 1 is to 100,000, which is, I mean, we have very few doctors, we have very few cancer hospitals that are treating cancer. So again, they were not able to devote a lot of a lot of time counseling the patient about how their quality of life is going to impact, or guiding them, or understanding what kind of mental trauma they're going through. But it is the nurse who acted as a counselor when the counselor was missing in the official hospital space. So exercise, healthy and active lifestyle definitely helped in better quality of life. Like, a lot of women were doing yoga, and they felt happier while doing that. Then role of external breast prosthesis is huge. It resulted in better external body image. Here, what I mean by external body image is that women felt confident while moving out, but when the breast prosthesis was not there, they still felt a lack, sense of emptiness, or that there was change in their body. So the body image was not completely healed with the breast prosthesis, but it definitely made things better for them. They felt normal while going out, and it definitely helped them to step back into the society and go to social spaces. Um, so some gaps that we identified is lack of awareness about the disease. Definitely, it is huge. Gaps at AIM, so All India Institute of Medical Sciences, we did some observations and some interviews there as well. So first was doctor-patient ratio. Of course, as I mentioned, it's very, I mean, it's the situation is pretty dire, where there are very few doctors with the number of patients that come there, hence making it impossible for doctors to counsel the patients, and nurse eventually takes up the role. Infrastructure issue is also there, where the rooms are very small, and again, because of that very reason, a lot of patients are waiting in the same room, whereas counseling is also happening just in the other room, and that leads to a lot of privacy issues. So no active organized breast cancer survivor groups are there in India, unlike West, where we have active cancer survivors group across the nation. In India, we don't have many. Few are being run by not-for-profits, but again, these groups are not run in a very organized manner. Lack of awareness about breast prosthesis is there, and low affordability of breast prosthesis and mastectomy bras is a huge problem, where people are just not able to afford silicone based prosthetics or mastectomy bras coming from other nations. So some thematic inferences where we saw that employment status, where employed breast cancer survivors had better mental health. Coming to income level, with the upper income group, they had more of elitist body image issues, like how am I going to wear a backless blouse, or how am I going to wear a strapless top after my surgery. Then the middle income group primarily faced financial crisis as well as certain body image issues, whereas the lower income group had more of parental family support. Many didn't mind getting their breast removed and wanted a definite treatment. Like they were more towards that, okay, just get my breast removed, but I just don't want to come to the hospital again because I definitely don't have resources for that. Coming to urban versus rural, in urban it was easier to explain, whereas in rural they wanted a definitive treatment, but there was a better social network and support. But again, in rural areas particularly, it could be seen the taboos existed at different levels, where often breast cancer patients were made to sleep on floors in their houses, because the family thought that maybe other people will get cancer by touching the person. So even these kind of taboos could be seen, and again all these things were told to us by peer counselors as well as the doctors. And again, educated versus uneducated also had similar kind of inferences. So age variances happened, where younger uh, group had a better the body image issues on younger women impacted more than the older women. With the younger women, there was worry of future and how they're going to face the society. Of course, mastectomy versus lumpectomy, the quality of life, the mental health impact, it was very different. And husband support, it is the husband. If the husband support is fine, the woman is more accepting towards her body, towards the changes that are happening, and definitely it leads to better recovery. So coming to case project, where we did a case on project Garima. Garima translates to dignity in Hindi language. So Project Garima is an initiative that is run by two organizations called Win Over Cancer and CanFilms Partnership, and where they work upon making affordable breast prosthetics and mastectomy bras available to breast cancer survivors across India. So this study was actually done where a project covered 600 breast cancer survivors who underwent mastectomy containing fabric-based breast prosthesis and mastectomy bras. So after implementation of this, after 3 months of them using the breast prosthesis and mastectomy bras, and then eventually also after 6 months. So first interview was done after 3 months, and then to verify the results, after 6 months, a sample of 140 people were taken, of breast cancer survivors were taken to do survey interviews. So coming to like other specifications of the project, the technology was approved of the breast prosthesis and mastectomy bras were approved by cancer institutes in India. So therefore they were good products. The cost, they costed 80% less than the silicone alternatives in the market. Therefore it could be afforded by most people, and they were easy to maintain and use, and they provided best comfort as well as secure fit to the patients. So coming to overall demographics of how the population size looked like, 92% of the survivors were from the younger age group, that is they were below the age of 60 years of age, whereas 67% did not wear a prosthesis before. And why this happened was because a lot of them could not afford the high cost of a silicone based breast prosthesis. Therefore 67% women in this project were not using any breast prosthesis before intervention of Winnover cancer and CanFem. Over 99% survivors did not find any allergic reactions to the prosthesis, and again over 99% women found that the prosthesis was comfortable to wear. Basically, they scored anywhere between 3 and 5 out of the 5 points that were to be given to the product, where 5 was the highest scale. So coming to some cases and how women, how we saw the difference. So over 100% of the women said that they felt more confident after wearing a prosthetic bra, that is breast prosthesis and the mastectomy bras that were provided to them by Win Over Cancer as per the survey. And as quoted by one of the breast cancer survivors, my body lost its beauty as a woman after surgery. It looked very ugly as one side was empty and the other side sagged. I had a lot of pain in my breast, but wearing the breast prosthesis helped. With the support, I don't feel uneven, unbalanced, and hollow from inside. I feel complete and beautiful. So almost all the women also cried while sharing their experiences. So the trauma of surgery, the trauma of the treatment was such, they thought that losing a breast had distorted their body image and affected their womanhood. They felt strange and incomplete after the mastectomy. As quoted by another woman, my appearance consciousness was at an all-time high after losing my breast. It was difficult to see myself without it, though I am a strong woman. So over 92% women shared that after wearing prosthesis, they felt more beautiful, which lost that sense of beauty inside them. But after wearing the prosthesis, after seeing themselves that their body symmetry is back, the clothes that they wear, they look pretty normal on them as it used to before. So they felt more beautiful after wearing the prosthesis. So again, as quoted by another breast cancer survivor, wearing that bra was almost like wearing my confidence again. Now I can travel freely, and as working woman can rejoin my job now without garnering any of those eerie looks. There is nothing to fear about. Try it once. So as per the survey, over 90% of the women expressed that after wearing the prosthesis, they don't feel embarrassed anymore. They don't get those kind of glares anymore on their chest, and this gave them more confidence, and it helped them to move out of their house with dignity. And as 97% of the people shared that Project Garma helped them to get back to their work after the treatment, because again, wearing that breast prosthesis, simple prosthesis, wearing that, it helped them to step out of their houses. So several women even felt extremely self-conscious without the breast prosthesis, and their minds remained preoccupied with the feeling that someone is constantly staring at their chest. I felt awkward feeling, I felt awkward walking without the breast prosthesis. I was not feeling good. My body posture was very different. There was a constant uneasiness because it seemed that every other person was looking at me or staring at me. So Win Over Cancer's breast prosthesis and mastectomy bra give women the best fit. And these kits are actually handcrafted and made as per women's very own sizes. After wearing the prosthesis and bra, the women tend to not feel conscious anymore, and this definitely gave a boost to their self-esteem. So as a conclusion, we can see that breast cancer and mastectomy impacts mental health of breast cancer survivors severely. Body image issues, low confidence, loss of sense of femininity, and low self-esteem are the most common thing that could be noticed. Women tend to stop going out of their house or avoid social interactions. Overall treatment impact their quality of life. Loss of body strength and change in body structure impacts their livelihood and their day-to-day activities. Breast prosthesis plays a very important role as a coping mechanism. Most breast cancer survivors in India cannot afford a breast prosthesis due to its high cost and low awareness levels of its importance. So not-for-profits and social enterprises can definitely play an active role in improving quality of life of breast cancer survivors, as it could be seen earlier. And in fact, lower price products which are of very good quality coming with advanced technology can be provided to these breast cancer survivors who cannot afford silicone based alternatives that are typically imported from European and American nations in India and other developing nations. So again, these mastectomy bras, these breast prosthesis, which is often ignored by the government, by even insurance companies in India do not cover these costs. So definitely these affordable options can come handy to these women and can impact their quality of life in very certain extent. So thank you so much. I am Akriti Gupta. This is my email address and this is my phone number. I am very, very much approachable and reachable to all of you. So please, I'm open to any questions, and let me know if we can work together or how I can help you with anything.
Thank you, Dr. Akriti. It was a very informative session, and I think the mental health is really very important. And thank you for reflecting very clearly upon it. And it is a major topic that is not being discussed very openly. Any questions from anyone?
Yeah, I feel really sad because like in India, there is no facilities like to do mammogram, which is screening to avoid all these issues. So I think the first thing that you need to do is to hold a campaign, talk to your government about that, how important to have the mammogram is available to all these women. Uh, and they are presented like late stages of breast cancer. And another question I have it to you, what is the cost of your product that you are presenting?
So it cost around $25. Like a typical silicon-based prosthesis costs around, I think around 100, anywhere between $100 to $200 in India. And whereas our product is just 1/4 of that price. So again, it is very affordable, and also it is made as per the needs of Indian customers. It is suitable for hot and humid climates. It is very easy to maintain because it is made using multiple layers of different fabrics, comfortable fabrics, and also it has weight inside it to balance out the body. And secondly, the mastectomy bras, they cost us $7. So again, it is very, very affordable for most women in India around.
And
I have a question.
sorry.
Yeah, thank you for a very interesting talk. Excuse me. There are a lot of Indian women in the United States. What's the experience of the Indian women in the United States? Have they accepted the Western mentality where mammography is common and mastectomy is not that bad and they can deal with it?
Thank you for asking this question, Michael. Unfortunately, this particular research did not include women of Indian origin, but residing in developed nations like US. But definitely, we studied certain literature where existing research was done on the overall context, that how, for example, women in United States feel after mastectomy, what kind of issues they face. So again, we could not find as such any study particularly done for particular ethnicities in such developed nations, but these particular studies even in developed nations shared that women had certain body image issues and femininity issues, but again the intensity of it is much higher in India because again other resources like peer support group, mental health services, and again breast itself being such a taboo subject, cancer being such a taboo subject, these kind of things already perpetuate. And again, access to breast prosthesis is not there at all. Insurance is mostly not there at all. So again, these factors, it just adds up to all these things. Yeah.
I can add to that. I know in the United States, African Americans usually do not like to get colonoscopy. Invasion of the anus is something that African Americans are not comfortable with. So early detection of colon cancer is not as good as it should be for the African Americans. So there are a number of cultural issues that affect oncology.
Thank you for that point. I would definitely like to read more about it. Yeah.
I just have one more question to you. You are a physician, right? So do you like consider immunotherapy in your practice for those cases with like advanced breast cancer?
Okay, so I would like to give you a little bit of my background, everyone here. I am actually not from medical background, neither am I from a mental health background, nor from like a medical background where I'm a doctor or a physician. I'm actually a social worker and a social entrepreneur, working in the field of cancer since I was just 17 years old. As my father, right here, he was a cancer patient. We just lost him in December. because of COVID, but he fought his battle with cancer for 10 good years. And he's my inspiration. He used to say that cancer is a beautiful disease because it teaches you to live life, love life, and enjoy every moment of it. So I have been working in the field of cancer since 7 years now. I am 24 years old and have recently completed my master's in social entrepreneurship. And all these studies, all these insights I have been able to do. Actually, if you say, I have been doing my primary research in the field since very beginning, but it's only in my master's degree when I realized that, okay, I can actually conceptualize what I have been working in the field in terms of awareness, in terms of the developing programs on how quality of life of cancer patients can be improved, because I saw that firsthand that how my father was suffering because there was no one to guide us, to help him become from a cancer patient to survivor and survivor to a normal person again, live in a back into the society in a very dignified way. So therefore I started these initiatives on my own, interacting with breast cancer patients, thousands of breast cancer patients, hundreds of doctors across India, connecting with various not-for-profits working across India. And that is how I started these two organizations called Win Over Cancer and CanFem, which are now working at national level, working on ground for cancer awareness, and again for cancer awareness as well, particularly focusing upon behavior change, that how we can nudge young women on practicing breast self-examination regularly, how we can reach out to communities deep inside rural India, and with the help of community workers themselves, how we can move towards breast self-examination practices, not getting cases diagnosed when the tumor inside a woman's breast has burst out, pus is coming out and it's literally stinking. Therefore the woman has to go travel 200 kilometers to a public healthcare center, a basic primary center, to get herself diagnosed. And before that she was not even coming out, because again breast is such a big taboo subject in villages around there, in tribal villages around there. So my team has been actively working on ground this way. Our team regularly goes to cancer hospitals. Unfortunately, today in COVID time, in India, like most of the cancer OPDs are working at just 20% of their capacities. Patients don't have anywhere to go to get their treatment done in this pandemic time. So our team coordinates with them, counsels them regularly that, okay, this is how you can manage the treatment in your hometown, and not go to just 4 to 5 cancer hospitals across India, which share the maximum cancer treatment burden. So this is more of my background. I would like to say here, I am not from medical background, I'm not from mental health background, but my field experience as a social worker, as a social entrepreneur, my daily interactions with patients, it definitely gives me a lot of energy and brings a lot of insights. And I work with a lot of physicians and a lot of mental health experts.
Good for you. Good for you. Actually, that's so inspired, and I'm sorry for your father. Yeah, my question to all of you, actually, all of who's attending the conference, about I didn't see anybody talking about the immunotherapy and how these women can get benefit from the immunotherapy, which is like the PD-L1. And keep what you are doing. And if I am in your shoes, I would reach out to the government to apply pressure on them to make the mammogram available for these poor women. Thank you for your presentation.
Thank you so much, ma'am. Thank you. We are actually with the government of Delhi now. We are actually trying to figure out a program where we can include breast self-examination practices, where actually on a prosthesis, like this is how the prosthesis looks like, how on a prosthesis we can practically teach women how to practice breast self-examination with the help of videos as well as with the help of physical workshops, and also get mammography vans so that it can reach out to remotest of the areas, and regular mammograms can be done in the population of 45 plus. But definitely thank you so much for bringing this point, Dr. Lubab. This is a very important point in terms of cancer advocacy and early detection. Thank you, ma'am.
Thank you, Dr. Akriti.
It's Miss Akriti for now.
Oh, sorry. Yeah, Miss Akriti. Okay, Dr. Lubab, I just got your question about PD-L1. Yes, PD-L1 is a very important point of discussion, but here in India, not many hospitals have the the kids to start with PD-L1 immunotherapy. Like I'm sitting in India and I'm from Jammu and Kashmir, and in Jammu and Kashmir, I don't think there's any single hospital which does PD-L1 immunotherapy to help the cancer patients. Yes, we do have PD-L1 in Tata Memorial Hospital or in Rajiv Gandhi Cancer, but then it caters to just a certain amount of people and it caters to a very small population group.
Yeah, I mean, it should be available for everybody. And here, like in USA, it's part of the, like, even you can afford it for free.
Yeah.
Because, like, yeah, I mean, it's not only for breast cancer now. Immunotherapy is available for most of the cancer and is FDA approved. So, I mean,
Yes.
it should be available. There's like, I don't know what to say and how to word this. I feel ashamed that people like in your country, there is no mammogram, there's immunotherapy is not available. I mean, you should do something. You are highly educated, and you should like talk to the decision maker or people who are in charge to make these things like available for like those poor ladies that um, you are talking about. I feel really sorry about them.
No,
And if you
ma'am.
need like any, I'm sorry, if you need like any like presentation for PDL1, I am like a expert in this field, and I started on 2018, and I see like 50 cases per day of PDL1, and now we are including the digital pathology, which is like an AI can read the slides instead of like manual reading. Manual reading can result like in an inter-observer difference, while the AI now with high accuracy, they can provide, or I should say, can provide the high accuracy reading for PDL1. Of course, not every woman is a good candidate for PDL1, but at least we can try. And I feel really, really sorry about those poor women. Thank you.
Thank you so much, ma'am. Actually, mammography is available in India. It is available in most of the places, but the population of India is as such, and we have such a huge area to cover that it is practically not possible to make it available in all primary health centers. So for that, the awareness among the women and among the people is very important. And for this, we need to work much harder, and we need to work in as like a very close society and help and educate the people about the disease and to cater the taboo issues which are related to this disease. Thank you so much, ma'am. And should we move ahead with the next speaker? So I would take the opportunity to invite Dr. Sana Garmani from Morocco to kindly start with the presentation.
Hello.
Hello. Hi, ma'am.
I think it's Sana Gamrani because you say it 3 times.
Okay.
Gamrani. Okay, so this is. Okay. So good evening. I'm Sana Agmani from the Medical Center of Biomedical and Translational Research, Faculty of Medicine and Pharmacy in Fez. I'm presenting a study about the prognosis and predictive value of estrogen negative, progesterone positive phenotype. This under the direction of Professor Arfat Mihin. It's a high qualified professor in breast cancer anatomopathology. So, the breast cancer endocrine therapy is importantly related to the expression of thyroid hormone, estrogen receptor, and progesterone receptors, which are one of the most efficacious prognosis factor and predictive markers in the hormone treatment. Progesterone receptors are often tested in parallel with estrogen receptor because extensive studies have shown that PR expression is conditionally on ER activity. It is easier to decide treatment strategy in case of double positive negative steroid hormone. On the other side, the existence of breast cancer with ER negative PR positive phenotype is continuous. So this is a retrospective study. We made it on a period of 7 years from 2012 to 2019, in which 1,195 59 cases were recorded in the hospital Hassan in Morocco. The objective of our study was to describe the clinical feature and outcomes of estrogen receptor negative and progesterone receptor positive. For this, a well-characterized and database of primary breast cancer was used. The cases were stratified according to ER and PR expression, and we were focused only on ER negative, PR positive group to highlight their future and to figure any prognosis and predictive value in comparison with ER positive, PR negative, and double positive negative tumors. For the histological analysis, it has been performed on formalin fixed paraffin embedded tissue section using hematoxylin eosin saffron staining. The histological grade assessment of tumors was established according to the Nottingham histological score system. For the immunohistochemistry assessment, all patients investigated in our cohort had the ER, PR, and HER2 status and K expression. The immunohistochemical analysis was performed on paraffin embedded tissue for the primary breast cancer and using antibodies according to the manufacturer's guidelines with immunohistochemical stainer, Ventana benchmark in our lab. At our pathology department, for all antibodies, positive and negative controls were routinely performed, including processing of normal tissue or tumor section. Receptor status was reported prospectively. Hormone receptor expression was defined as presence of more than 1%, and patient with zero staining for her hormone receptor was repeated twice and then considered to have negative expression. HER2 was assessed using immunohistochemistry or fluorescence in situ hybridization fish for equivocal cases. Immunohistochemical score of 0 to 1 were defined negative, and scored +3 were defined positive tumors. Score 2 were tested using fish. The statistical analysis in our lab was made using SPSS 23 statistical software. We evaluated the association between the ER negative, PR positive profile and other clinical pathological features using T-square test, Fisher's exact test as appropriate. The survival curves were performed using the Kaplan-Meier method and Cox regression to evaluate prognosis markers. Tests were statistically significant if P is under 0.05. For the follow-up, overall survival duration was defined as the time between the date of diagnosis and death resulting from breast cancer. The last follow-up visit, death being scored as an event. The disease-free survival was also calculated from the date of the first diagnosis and the date of first distance or local disease recurrence. For the results, we do a representation of different hormone receptor profile according to the age, the ER and PR status, the SBR grade, tumor size and nodal metastasis, and also HER2 expression. In the current study, a total of 1,159 women with primary breast cancer were included retrospectively for the duration of 7 years from 2012 to 2019. The median age at diagnosis was 40 years old, 48. For the age, the median age at diagnostic was 48 years old. And for the ER and PR status, out of the informative cases, 94 patients had ER negative, PR positive breast cancer, while 58 of cases were ER positive, PR positive, 88 were ER positive, PR negative, and 40.2% had ER negative, PR negative tumors. The SBR gradient patient, 53 patients had grade 2, and 35 patients had grade 3, and only 10% of patients had grade 1. For the tumor size and nodal metastasis, there were 57.9 patients who had positive lymph node, and 42 had negative lymph nodes. For the tumor size, there was no statistical significance among the hormone receptor profiles. But all groups had tumor size more than 2 centimeters. For the HER2 expression, all patients shows a significant negative expression of HER2 gene. The clinical pathological characteristic of 4 ER/PR profiles of included patients show that 690 of patients were younger at the time of diagnosis, under 50 years old. There were a significant statistical difference between the groups. In comparison, the double positive and ER negative PR positive were younger than ER positive PR negative and double negative. There were a significant also difference across hormone receptor profiles. To compare double positive hormone receptors and ER negative PR ER positive PR negative groups had the highest frequency of grade 2, while most of the patients in ER negative PR negative and ER negative PR positive had grade 3. Our results showed lymph node statue was statistically significant. The frequency of positive lymph node statue was higher than negative lymph node statue in each profile. The tumor size was not statistically significant among hormone receptors profile. The frequency of high tumor size was higher in each group. All patients shows a significant negative expression of HER2 and low proliferation index. Then we do a clinical pathological characteristic of ER negative PR positive and the breast cancer subtype. In this time, we subgroup the ER negative PR positive according to HER2 statue, and we have comparison on between ER negative PR positive HER2 negative, ER negative PR positive HER2 positive, ER positive PR any HER2 enriched and triple negative breast cancer. The analyzed profile of hormone receptor expression differed by age at time of diagnosis. The ER negative PR positive HER2 negative beside the ER negative PR any and HER2 enriched patients were younger, while the ER negative PR positive HER2 enriched and triple negative patients were older, but no statistical significance was shown. Almost all patients shows a very statistical significant correlation to high grade 3, in contrary to big parts of ER negative PR positive patients who were grade 2. Then no significant correlation was observed to tumor size, even that all patients present a high tumor size. Indeed, the lymph nodes statue was statistically correlated. The percentage of negative lymph node statue was higher in ER negative PR positive HER2 and triple negative. On the other hand, the positive lymph node statue was more often present in ER negative PR positive HER2 positive and ER negative PR any and HER2 enriched subgroup. Then the survival analysis shows that from the breast cancer cohort analysis, a significant association was found between the 4 hormone receptor profiles and outcomes. However, there was no visible difference between ER negative PR positive and ER positive ER negative. And then they were shown in midway between double negative and double positive. Then we studied survival analysis for the ER negative PR positive group, but according to HER2 statue. The analysis of whole breast cancer cohort shows a significant association between the breast cancer subtypes and outcomes. However, a low DFS was observed in patients with ER negative PR positive HER2, which is closer to that of triple negative and worse than ER positive PR any. On the other side, the ER negative PR positive HER2 positive shows also a poor DFS more closer to HER2 subgroup and between triple negative and ER positive PR any, presenting the highest DFS. Moreover, the curve of ER negative PR positive HER2 negative subjects appear to mirror of HER2 enriched subjects for over than 50 months. Additionally, the OS estimation of ER negative PR positive HER2 negative and ER negative PR positive HER2 positive were closer, classifying them in midway of the ER negative PR any and triple negative HER2 enriched. The ER negative PR positive HER2 group seems to most increase the risk of recurrence than ER negative PR positive HER positive compared to ER negative PR any. For this, the ER negative PR positive HER2 seems to most increase the risk than ER negative PR positive HER2 negative in comparison with ER positive PR negative PRN. The hormone receptor status is an important prognostic and predictive factor in breast cancer. To our knowledge, this is the first study in Morocco to highlight the predictive and prognosis value of ER negative PR positive. In our study, 1,159 cases were explored. We had 9% of patients had ER negative PR positive, reported by the literature. Compared with different groups of ER PR expression, all patients were younger at the time of diagnosis. The median age was 50. This association has been described by other studies. In comparison with ER positive, the ER negative PR positive are mostly likely to be high grade and more likely to have overexpression amplified tumors. On the other hand, the ER negative PR positive groups are less likely to be high grade in comparison with double negative. Those results has been shown previously by other studies in our series. The ER negative PR positive was related to large tumor size and positive nodal, but no significant difference was shown between different groups. Furthermore, a study classified ER positive, PR negative, PR positive, ER positive, PR negative, ER negative, PR positive, and ER negative, PR negative subtypes from the good to worse according to breast cancer series. But this study has some limitation, weakening the robustness of the finding. Another study reported that single positive hormone receptors profile are associated with poor disease-free survival and worse than double positive hormone receptor tumors. But they found that single positive hormone receptors tumors are associated with poor survival similar to that of the double negative hormone receptors subtypes in HER2 negative breast cancer, but no difference in survival among the 4 subtypes in patients with HER2 positive disease. The low death rates of ER negative, PR positive, HER2 negative, and ER negative, PR positive, HER2 positive are closer respectively to triple negative and HER2 enriched, characterizes them as poor prognosis than ER positive PRNE. Additionally, the OS estimation of the ER negative PR positive HER2 and ER negative PR positive HER2 positive were closer, classifying them in midway of the ER negative PRNE and triple negative HER2 enriched. The ER negative PR positive HER2 seems to most increase the risk of recurrence than ER negative PR positive HER2. To conclude, this phenotype is associated with high grade and HER2 overexpression amplification and appears more in younger women presenting an aggressive behavior. The ER negative PR positive tumors is clinically distinct group. It may need a different treatment strategy and has shown a high aggressive behavior than ER double positive and less aggressive behavior than double negative. We have explored the biological characteristics and outcomes of the ER negative PR positive according to HER2 statute. In addition, after analyzing the groups according to HER2 expression, we revealed that 2 distinct groups which give to ER negative PR positive subgroup heterogeneity characterization, and this finding occurred for further studies and clinical trials to explore behavioral characteristics of single hormone receptor in order to optimize the treatment management for patients with single ER negative PR positive breast cancer. Thank you.
Thank you so much, Dr. Sana. Any questions?
May I ask a question?
Yes, sir.
Thank you very much for the presentation. First of all, I want to know the number of cases. I think something about 9 or 10% of the cases were ER negative, PR positive. Is it right?
About yes.
About 9% of 10%, I think, of cases
Yes.
with PR negative and PR positive. Are you sure that you didn't have any technical problem in this study? Was the fixation time, ischemic time, anything analyzed in this study correctly?
For the technical issue, that we did have some problem with the fixation, but if as you can see that we repeat the immunohistochemical for each patient, if we had like zero expression to see to be sure that the patient doesn't express the AR negative or PR positive. And we use also the control positive and control negative. So for the technical issue, that for a technical issue for immunohistochemistry, I think that we limited them with this.
Do you record the ischemic time, cold ischemic time in your institute? Do you know what is the ischemic time of your case?
Ischemic times?
Yeah,
No.
time when the tissue comes out of the body until it goes into the formalin. It's called cold.
Yeah, sometimes because sometimes it's directly from the operation to our lab, but sometimes they take like 1 hour or half an hour. So I think that's.
You know, the problem is that in my experience, the number of cases that are ER negative, PR positive is much, much less than what you have found here. And as a matter of fact, some few cases.
We had 8%. 8% of patients that had ER negative, PR positive. 8%.
Yeah, it seems a little bit, you know, just a few cases I had, you know, breast cancer with this kind of expression. And in all of the cases, I had some technical problems. You know, the fixation was probably not good. It was some kind of autolysis, or the ischemic time was long. You know, it's a kind of issue that really should be considered. And
yeah.
That ER negative, PR positive group even is not accepted as a real group by some authorities. But your study showed that the results of cases that are ER negative, PR positive, and HER2 negative, you know, the outcome was the same as triple negative. Is it right?
Yes, but they are closer. Yes.
Triple negative, and in cases that were ER negative, PR positive, but HER2 amplified were just like HER2 enriched group. Is it right? Close.
Yeah. They are closer, but they are not identical. So they have some difference in the clinical pathological characteristics.
Mm-hmm. Probably it shows that you know, if these findings are in favor, that probably. And I want to know that you know, the percentage and intensity of PR positivity in cases. Do you have any you know, idea about the percentage and intensity of PR positivity in cases of ER negativity? You know, where did you have a case that was ER negative but PR intensely positive, or with you know, a high percentage of cells?
Can you please repeat your question?
You know, my question is that do you have or did you have cases that were ER negative, but the PR expression was both, you know, occurred in a large percentage of cells and with high intensity? I want to know.
Yes, yes. Sometimes we had like ER negative, but the PR was positive as more than 50% or 60% of cells.
Yeah. Thank you. Thank you very much.
You're welcome. You're welcome.
Thank you, Dr.
Yeah, that
Sana.
was like That was a good question, actually. I would like to ask, what if like you have like the PR is 5%? What do you call it? Do you call it positive or negative? I
PR.
mean, I'm sorry. I mean, the expression is 5%. So what do you call it?
It's positive because I already mentioned that we consider 1% as positive expression.
I mean, from where did you like get this cutoff? Which reference did you based on?
We took this reference to say that we are sure that the ER negative is really negative, but not there is no expression.
No, I mean, I'm talking about the reference range. You mentioned 1%. So did you use like a certain guidelines to?
Yes, yes, of course.
Do you mind?
There are many studies.
Do you mind to share these guidelines?
Guidelines. I took like other studies as the experience of other studies.
Oh, got it. Thank you.
You're welcome.
Thank you, Dr. Sana. Any more questions? I think that's all. I would like to thank all of you for taking out your precious time and attending this conference. I thank all the keynote speakers, all the speakers who presented their work and graced this occasion of Breast Pathology Conference. We have another conference that is coming up in August. That is the 8th Emirates Digital Pathology Conference, and I request all of you to kindly register for that conference. We have many great speakers who will be gracing the conference, like Dr. Anil Parwani, who is the Vice Chair, Anatomical Pathology, Director of Pathology Informatics and Digital Pathology, Dr. Philip Mekki, Dr. Zeev Leiper, Dr. Joan Martin, Dr. Andreas Luke, Dr. Joan Martin, Dr. Marilyn Bui. They all will be gracing the occasion. And as far as this conference is concerned, many of our speakers could not present the work, present and attend the conference due to the ongoing pandemic. So their online videos would be available by or on 15th of June, and you can kindly see their work through that mode only. Thank you all for taking out your time and attending this conference with all of us. Now I'm handing over the stage to Dr. Monal Trisal for presenting the vote of thanks.
Thank you, Dr. Ishani. So it was an honor to be among such accomplished individuals, and for presenting your perspective with us. Thank you and good evening. I admire all the speakers, all the keynote speakers, all the interactions, all the queries from the delegates and the healthy discussions. Both days were very good and very informative. The complete conference session video will be available on YouTube and broadcasting sources. The certification will be provided on June 3rd, 2021. Looking forward for our next conference. Be there. We wish you be there. Thank you. The next thanking speech will be by Dr. Jyotsna Suri. So with this, we end our 2 days breast conference session. It was very informative. We learned a lot. Looking forward for the next 8th Emirates Pathology and Digital Pathology Conference in August 10 and 11. Thank you so much. Thanks everyone. Thanks all delegates and speakers, keynote speakers and chairpersons.
Hello.
Hello, Dr. Ali. How are you?
Yeah, I'm sorry for my absence for a few minutes. Actually, I would like to thank all of you as well, all of the speakers, presenters, our keynote speakers. and also the team for making this 2-day conference such a great success, and hope to meet you all again for the next conference in August. Thank you.